show you. Maybe the program could display here as we go. So we will have some welcome remarks, and then we'll get into the panel discussion. Kama hujakunywa chai asubuhi, I promise kuna nafasi ya kukunywa chai tena kwa program. So hatutaki mkuje na njaa, mwende nyumbani mkiwa na njaa, and then mseme Nation Media hatujui kulisha watu. We know how to feed people. So we will make room for you to have tea in the program. Ladies and gentlemen, without further ado, I would like to welcome Monica Ndungu, who is our Chief Corporate Affairs and Partnerships Officer at the Nation Media Group, to take us through the next part of the program.
Good morning. Good morning. Maybe Zainab, you're flowing of the blood. you need to do some bit more work, but good morning, everybody. It is a pleasure to have each and every one of you here. And to the Principal Secretary in the Ministry of Health, Mary Muthoni, our esteemed speakers, who are many and who we are all looking forward to listening to today, our valued partners, again, who are many and are exhibiting their work at the tent just behind this one, distinguished ladies and gentlemen, good morning. I stand here on behalf of the Nation Media Group and our group CEO, Mr. Geoffrey Odundo, and welcome each and every one of you to this third edition of the Nation Health Summit. Thank you for taking your time, whether you're with us in the room, or you're watching us on our many digital platforms. Thank you for taking your time off your busy schedules to be part of this crucial conversation. It is encouraging that you have shown such strong commitment that is going to help in advancing the vital conversations, policies, and actions that are so desperately needed in our health sector. It is with immense pride, and as you can see on your screens, that I say we host this third edition that has the theme towards a healthier population, innovating to accelerate achievement of universal health coverage. And with this event, we continue to reaffirm our unwavering commitment to positively influencing society, which is a core tenet of our mission. This summit arrives at a critical juncture for healthcare in Kenya. Some of the data paints a stark picture of some of the challenges we face. There's a significant burden of both communicable and non-communicable diseases, but there's also great progress around maternal and child mortality rates, though they still demand urgent attention. Issues like access to quality healthcare, affordability, infrastructure limitations, and a shortage of health professionals sometimes impede our journey towards universal health coverage. It is in the backdrop of this that Nation Media Group becomes not just important, but absolutely indispensable. As Nation Media Group, we are the eyes and the ears of our nation, tasked with informing, educating, and holding power not just to the ones, holding accountable, not just to those in power, but also to the citizenry. In the realm of this health responsibility, we take on an even greater responsibility, and we look at it in the following ways. One is to illuminate our challenges through our platforms. It's to bring to the forefront realities of the challenges I've spoken to. The second one, our role is not just to bring to reality those challenges, but it's to champion solutions and innovations that are happening across our country that facilitate UHC. The other is to empower the public. Across our platforms, we aim to provide accurate, accessible, and timely health information that empowers individuals to make informed decisions about their well-being and advocate for their health rights. And the other is to facilitate dialogue, to create spaces like at the Nation Health Summit for policymakers, healthcare professionals, researchers, civil society, and the public. This commitment is deeply embedded in the fabric of Nation Media Group, and we recognize that contributing meaningful to the health discourse requires us to do than just mere reporting. And it demands that we constantly and consistently engage and create content through our platforms for sustained dialogue. And that's why, as you can see again on your screen, to allow us to live our mission, which is to positively influence society, we have our Healthy Nation pullout, something that you should have access to where you're seated. We have Heartbeat that runs on NTV. We have Afya Yako, a Swahili program that also runs on NTV and includes a segment called Ask a Doctor. We also have the Afya Kuu pullout on our Taifa Leo, the Health Diary Show, the One Health podcast, the Health Assignment weekly digital-only series, Nation X Spaces, and the Nation Health Summit, of which you are part of today. These initiatives are not merely journalistic endeavors. They are integral parts of our commitment to continuously positively influence society. And they are designed to inform, educate, but also more importantly, to convene. This summit continues to be part of that commitment, and it's a vital opportunity for you who have come to join us today, those joining us online, those who have participated in other ways. And it's a space for us to learn together, deepen our understanding of the complexities of healthcare, for us to openly then engage in dialogue, and ultimately to forge pathways that lead to meaningful policy changes and tangible improvements in the health and well-being of us all. Over the next 2 days, and I'm looking forward to those next 2 days, you and Nation Media Group, across all our stakeholders, will engage in robust conversations, explore those solutions that, again, I said, are being exhibited in the tents behind this one, and we will look at how each and every one of us play the role of accelerating the achievement of universal health coverage. So I beseech us and ask us, those in the rooms and those outside, to embrace this opportunity with a spirit of collaboration, a shared determination, and build a healthier future for Kenya. And with those few remarks, allow me to welcome, and we are privileged, and Zainab said we are, and I continue to say we are privileged to have the Principal Secretary, the Ministry of Health, Mary Muthoni, and I now welcome her to come and give us her remarks. Let's give her a hand clap as she comes.
Thank you very much. Hamjamboni. Good morning. Good morning. Please tusalimiane hata kama sio kanisa, lakini we need to verify whether you are right or you've woken up okay. Ladies and gentlemen, and I can see even my friends who are here, I can see my team who is here, and I'm happy. I'm quite privileged to have been invited to this forum. Maybe just to say this is just one of the many platforms that we miss to also talk to Kenyans and also share ideas and see where we can meet and have a convergence. Because health is a collective responsibility for all of us. I want to take you back where we started with the Ministry of Health. And I have seen the pullout today, the long road to UHC. Indeed, it's been a long road to UHC. And I'm more than convinced that this is the time that UHC must work in this country. When the government came to place in 2022, the first thing and the first assignment that was given to the Ministry of Health was to formulate laws. And we enacted 4 laws. You know, a law is a base. Because you don't want to build something that is going to crumble tomorrow, where nobody has no reference. And the first law was the Primary Healthcare Act of 2023 that incorporates, these people are found in the screen, the community health promoters. The second one was Digital Health Act of 2023. Only yesterday, we have realized that even when a doctor goes to treat someone, you will need to enter your number. Unlike before, when you would never find information of who treated you last year, or even corrective issues that can be taken up by another doctor. Equally, putting away the books, the exercise books, the quota exercise books that we grew knowing that the doctor has written a prescription, but when you're referred to another facility, you have no reference because probably that exercise book has already been rained on or something, or destroyed. And the third act that we established was the Facility Improvement Financing Act of 2023. Ladies and gentlemen, let me just tell you something, that it is not that there's no money for health or there has been no money for health, but many a times is when we used to see budgets reallocated, money that is meant for health, for commodities, for infrastructure, for equipment, reallocated for other functions. And we needed a law to ring-fence these amounts so that they can do the work that 80 is intended for. And finally, ladies and gentlemen, is the Social Health Insurance Financing Act of 2023. If I tell you that only 20% of our population would access health facilities and services through our NHIF, the National Health Insurance Fund, sorry. And we only had one fund for that matter that catered for that 20%. And it was 20% because most of them were employed, like you and me. The informal sector could not access services that were offered at any health facility. Hence, there was need to come up with an insurance or an authority that will oversee that every other Kenyan accesses services available, affordable, accessible, and acceptable quality healthcare. That is why we came up with the laws, that there is equity even in the access to these services. And just moving on, I know some of the questions that many people will be asking. How do you tap in then the social sector, the informal sector, that is 80% of our population? Really, we have seen that in the Social Health Authority, through the Social Health Insurance Fund, we have subsidies for the poor and the vulnerable. Hence, we are able to also reach out to those people who cannot be able to pay even a penny, and the government is going to pay for them. And let me just break it down for you. The Social Health Authority has 3 funds, as opposed to the one fund that was the NHIF. We have the social health, we have the Primary Health Fund, which is taking care of the primary level facilities so that if you go to those facilities, that is the level 2, level 3, which is dispensary and health center, you do not pay a coin. We have the Social Health Insurance Fund, our pooled funding, where me and you are paying. And we have the Emergency, Chronic, and Critical Illness Fund at the same time. But we are saying if you cannot afford to pay, then the government should pay for you. Again, the informal sector is a whole constituency where we have chamas, we have SACCOs, people meet in churches, local cooperatives, and sometimes they pool funding together where they even borrow from each other. Where they even borrow each other and encourage collective responsibility or contributions. That is the informal sector. So it's a whole constituency which me and you, and especially the media, who I call upon, that we join hands, because the essence is to ensure that everybody, every Kenyan, is accessing services. I have been asked many times on the Kenya's specialist to population ratio, which they say is critically low, and what comprehensive strategies that we are looking forward to. In the Ministry of Health, we have postgraduate training. Remember, health is a devolved function, and the role of the national government is training, while the county government is supposed to do the implementation. The national government does the training and policy formulation. Therefore, when we are looking for different cadres and equally different specialists, we are doing a needs assessment for the counties, where these particular cadres work, whether it's a doctor, nurse, clinical officer, and many other cadres. And we want to find out in a specific county, what is your need? If you need to take a patient to ICU, do you have the critical staff that is required to assist in the same? Therefore, after the needs assessment, we continue to do postgraduate training to ensure that we have the different specialists in our country. Remember, we may have all the digitization that we want. We may have all the new equipment that we want. We may have the best infrastructure in the world. But if we do not take care of the human resources for health, then we are in it. We are the ones to blame. So as a ministry, we are very keen about the human resources for health. And we want to make sure that we have all the specialists that the country needs at any given time. Therefore, developing healthcare professionals policy is very key, and that we are already doing. In fact, we are in the process of developing the human resources professionals policy that is going to take care of all people who are working in the health space. Equally, we have already said that we are expanding the specialist training, which is required for the country to build local capacity for the facilities, because every other day we are opening new facilities, both in private and public sector. It is important to note that there are quite a number of public health events that you have seen in the recent past. And sometimes we wonder, maybe the members of public ask, what is the Ministry of Health doing? You've seen the issue of cholera. We have a cholera outbreak right now in the country, in Kisumu, Migori, even Nairobi, where we are seated. So I hope there is a wash point machine out there, madam. And if there is none, I will request, as we progress, we put some wash point out there so that when members of the public are coming in, they wash their hands. When they are going out, they wash their hands. It is the small things, the tiny little things that we ignore that make the difference. And I want to encourage anybody in this country that when you wake up, wash your hands. When you're going to work, wash your hands. When you get to work, wash your hands. Practice. You will influence the rest of the people who work around you, and you will see the difference. We will not see outbreaks like cholera in this country anymore. It starts with you and me. These are practices that we can experience as we move forward. And it takes somebody or one person to start, and everybody else will follow. So we have cholera outbreak in the country. We've had Mpox outbreak in the country that has seen more than 70 cases confirmed. We have Kala-Azar in the northern Kenya. Now, I want to confirm to the country that during COVID, we built a lot of structures in place, and those structures were never destroyed. We are building up on the same. We have enhanced our surveillance in the country. If you go through any border today, you have to be screened when you're coming in to ensure that you are okay, whether it is land, sea, or air, through Jomo Kenyatta, Malaba border, or even Lunga Lunga and any other. So we have enhanced our screening. We have also enhanced our surveillance. Our teams are always on the ground to check or detect anything that would be in the communities. We have also improved in the terms of allocation of budgets. We have seen the National Treasury allocate budgets that are meant for any eventuality or any public health event. We are equally improving on community engagement and especially risk communication. For instance, what I'm simply just telling you, that wash your hands. It sounds very basic, but it means a lot. We have come up with programs like Epuka Uchafu, Afya Nyumbani. And Epuka Uchafu is a 3-agenda issue. Personal hygiene. Even when our children are going to school, a basic issue like giving them a handkerchief is enough so that when they go to sneeze, they will not sneeze on other children. So personal hygiene, your body hygiene, and what we are talking about, washing of hands. Environmental hygiene, when you look at what is happening in the communities today, most or many diseases are actually preventable. Even if you talk about vector-borne diseases, like malaria, waterborne diseases, cholera, dysentery, and many other diseases, they are preventable. You simply just need to cut the bushes around your household. You simply just need to drain the water around your household so that we don't have cholera. And equally practice issues of water and sanitation. Water is life. We still have 15 counties in this country that practice open defecation. Remember, if your neighbor has no toilet or has no latrine, if they go defecate in the coffee farms or in the compound, when the rains come, that is going to be swept near your home or right in front of your house. And you have a 2-year-old who is going to play with that kind of dirt. Therefore, it is important that we encourage even our communities to have clean water and to also practice good sanitation. It is important to note that our rolling out of community health promoters, 107 831 community health promoters is a game changer, and especially in our communities, in our households. These people have only one role: take your blood pressure, blood sugar, and we have trained them. So don't think huyu alifika mpaka form 4 sasa anajua aje mambo ya daktari. We have trained them, we have kitted them, and we have given them a phone, a smartphone, to record data, because the decisions that we are going to make in any public health issue is going to be data driven. So they collect data on a daily basis. And they remind mothers and caregivers that it is time for their children to go for vaccination. They remind teenage mothers that it is important for them to go for prenatal care. Remember, a 16-year-old sometimes feels embarrassed that she's gotten pregnant. She does not even want to get out of the house. Our community health promoters have been trained to take care of this group of people and ensure that they are getting services and also the medication that they require at any given time. Therefore, public health, me and you have to ensure that we are reaching to the goals that is intended. Public health education and communication, literacy levels, and especially on health promotion and education needs to get to some level. Nation Media Group, I am inviting you that we join hands, because this is basically me and you ensuring that the members of public get the right information. Many people have asked about the geographical distribution of healthcare, specialists that it's heavily skewed towards the urban centers, and what policy interventions can ensure equitable distribution of medical expertise across rural and urban areas. I want to tell you, we don't need new policies. We only need to implement them. And that is what we are enforcing at the Ministry of Health. We can amend 1 or 2 lines, but we don't need new policies every other day when we have books, booklets, and so many other documents that are getting dust. The one thing that we need to request employers is to ensure that they have enough incentives for our human resources for health. Ensure you pay them better, ensure there is progressive retention of the same, and ensure that we also have decentralized training and recruitment. Health is a devolved function. Therefore, many of the issues will be done at the county level, because most of these employees are at the, work at the county facilities. So improving their working and living conditions, we have the policies, we have the laws. Let us implement them. We don't have any other way. We don't have a shortcut. And of course, leveraging on technology. We have our digital superhighway that is going to have all the healthcare workers in one registry to ensure we know who we are working with, where they work, and at what point they have done certain services. We do not want to have patients having a knee replacement 10 times in a day in one facility. That is why we are digitizing everything. Community health strategies, equally. And The one thing that we also need to improve is guidelines on sharing medical specialists. Right now, you have to be employed in a certain county for you to work in another, or if you need to transfer. It would be important that we have or improve on the guidelines on sharing medical specialists, so that if we have a shortage, should we have a shortage at any given time, then inter-county sharing of specialists can be encouraged at any given time. Now, I don't want to repeat about how patients have been going out of the country, because we know why patients have been going out of the country, because of lack of enough specialists. And I have already talked about the postgraduate training that we are doing. And this year alone, we have admitted about 70 specialists who have gone for postgraduate training. Therefore, it is important to continue looking at issues that are going to improve the health sector in this country. And I reiterate, the laws that we came up with is to ensure that we have a firm foundation for the health sector, a firm foundation for the people of this country, a firm foundation for me and you. Thank you very much for inviting me. I will be ready for any question, should there be any. I'll stick here for some time so that we are able to have a conversation. I always advocating for conversations, genuine conversations. There could be something that we are not doing right. I want to hear it from you. And I'll tell you for a fact, we admit that probably SHA may not have been 100%. But we did not just sit pretty and say, let's see how it will go. We went back and asked the members of public, where are the pain points? Already, some of the tariffs that used to really be painful to the people have been reviewed. Our ICU bed would only take 4,000 shillings. Right now, we have improved it to 28,000 shillings. Oncology, very many people would go to facilities and they are told, SHA haiwak. Kwa sababu gani? You'll go for chemo 1-2 times and you're told, it is over. Please go back to your pocket. The money was only 300,000 shillings. We have improved the same to 550,000 shillings. It is because of you. You comment, we pick, we analyze, and we act. The government has a listening ear. The Ministry of Health has even a better listening ear. Have a great day.
Thank you very much, Madam PS. And I'm glad you said you're going to stick around for some time, because we'd like to invite you to join the next panel. So, ladies and gentlemen, I'd just like to let you know that the tent behind us over there, I don't know if you've had a chance to pass through it on your way here. The tent behind us over there is an exhibition point for various services. And some of the services you'll find there include free medical and wellness checks. So and those medical checks include, by the way, cancer screening. The PS talked about cancer in her statement. So there's also cancer screening available there. And we have ensured that your privacy will be maintained throughout those screenings. So usiogope, ati watu wataona, watu watasema nini. There's privacy there. So I hope you find time to pass by there. Now, ladies and gentlemen, distinguished guests, healthcare professionals, champions of change, I see very many bright minds in this room today, and we stand at a critical moment in our nation's health journey. Universal health coverage, as the PS said, is not a luxury, and it's not a political slogan. It is a fundamental human right. You have a right to that as envisioned in the Constitution, but the question is, can you access it? Have you been able to access it? Have you had challenges to access it? And I'm glad that the PS has recognized the challenges that they face. So, you've heard about the communities that have to walk tens of kilometers, sometimes even hundreds of kilometers, in order to access healthcare. Something as basic as a dispensary is not next door. And this is particularly common for communities in the marginalized lands. You've seen of communities that have to sell everything they have in order to seek medical health care. And you're familiar with the statement that we are all just one illness away from poverty. That is the reality for millions of Kenyans. Maybe you might have the luxury to get healthcare right now because you're employed and you therefore have medical cover. But for many, many Kenyans, the story is different. And right now, only about 20% of Kenyans have access to health insurance, even with the SHA that the government is trying to get everybody to get registered to. And out-of-pocket expenses consume nearly a quarter of your total healthcare expenditure. Can you imagine that? A quarter of your healthcare expenditure. Bado hujaongeza rent, bado hujaongeza housing levy, bado hujaongeza pay kwa hiyo expenditure. And the doctor-to-population ratio right now stands at about 1 to 6,000, which is so far below than the recommended WHO standard of 1 to 1,000. So which means if you're seeking a doctor, it is therefore not uncommon for you to be waiting in line all day just to see a health professional. But the good news is we are not here to tell stories of despair. You read about those in the newspaper every day. Here, we are here to tell the stories of potential and the stories of possibility, the what could be, the what our future, our collective future could be. And today's panel, therefore, brings together some of the most brilliant minds in healthcare, individuals who are not just observing these challenges, but are actively working to transform them. And so I would like to welcome on stage Ms. Mary Muthoni, our PS of Health, who is at the forefront of crafting national health policy. So she'll tell us a little bit more of the things she just mentioned in her statement. I'd also like to welcome Dr. Meshach Ndirangu from Amref Health Africa, who understands healthcare from the ground up. Amref, mnafanya kazi mzuri sana. Asanteni sana. And I'd also like to welcome Mr. Leonard Cosmas from the World Health Organization, who will be bringing global perspectives to this conversation. And last but not least, I welcome Alan Maleche from Kelling, who's ensuring that healthcare is not just a service, but a right. Now, ladies and gentlemen, this is not just a panel discussion. Like I said, we're not here to tell stories of despair. Consider this a strategic session, a brainstorming session, a collective effort to diagnose our challenges and understand their roots, and also chart a path forward. So you as the audience also have a role in this strategic brainstorming. Please note down any questions you might have, any interventions you might have, any solutions you think the panel here has not addressed, and then we will address them at the end of this session. And as we've seen on the screen here, our theme is very clear: the state of universal health coverage in Kenya and Africa, the progress, the challenges, and the way forward. That's what these lovely people in front of us will be discussing today. It is not a story of despair, I repeat that. It is not a story of despair. So we are going to dive deep, ask the hard questions, and demand accountability. So I encourage you to also demand accountability. Uzuri tuko na serikali hapa, so hakuna cha serikali saidia. Maswali mtauliza serikali hapa, akwambie kama inawezekana ama hapana. Yeah? Because universal healthcare at the end of the day is more than just a policy, right? It is a promise for a better Kenya and leaving no one behind. So I hope we do that in this panel today. I can ask assistants to remove this podium here. Thank you. So let our conversations begin. And I want to start with the PS, where you left off, the ambitious targets of UHC, promising healthcare to everyone, ensuring no one is left behind. Lakini kwa ground, vitu, they're not as rosy as they appear on paper. We still have challenges of people who still can't access basic healthcare, people who still have to walk hundreds of kilometers to get to where they need to go. And recently, the nation did a story of a community in Kajiado County that has to cross the border into Tanzania in order to get healthcare, because that Tanzanian facility is much closer to them than a Kenyan healthcare facility. So, how then do you respond to the critics who say UHC is more of a political slogan as opposed to actually making lives better for Kenyans?
Thank you very much for that question. Indeed, I will not go with your slogan that vitu kwa ground ni different. I will first take cognizance of there are good things that have happened. Even with all the noise, there must be at least one or two things that you have seen that is good. Number two, we have come to the point of going specific. Let us not generalize everything and say that facilities are not admitting people, we don't have doctors. In my statement, I said we are doing a needs assessment for counties to get to know which county requires who. Is it an obs-gyna? Is it an oncologist? What do they require? Because it's not that we don't have those people around. We have them. So where do we need to improve? Who do we need to train? And who do we need to hire at any given time? And that calls for also infrastructure. What needs to be improved in the facilities? I am for mothers being given dignity when they are giving birth. That we don't need those halls where women are just thrown in and they are told now you can give birth and scream together. There must be some decency. So are we improving our infrastructure in that manner? That a mother can have their own small room where they can give birth.
And give them privacy.
Again, yes. And again, equipment. We don't want people to go to facilities and there is shortfall in terms of equipment, the right equipment for that matter. But can we go specific? Which facility, which county, and where is the problem?
Are you saying, therefore, that you're trying to build expertise for specific counties, that if you're looking for oncology services, go to this county?
Absolutely. And I said it very clearly. We have a program for postgraduate training where medical practitioners go back to school to train for the specialist, the area that they want to improve on or to advance in. Secondly, you've talked about the issues that are in the community. I want to say, I talked about ring fencing health funds meant for health. That is why any coin that is meant for a health facility, and if you go to SHA right now, how the money is wired to the facilities, the level 2 and level 3, we don't have many steps to get there. The money is sent directly to the facility. Why? Because we want that particular facility to improve on whatever that could be missing. May it be a health worker or probably the infrastructure, the commodities, you know, the equipment, sending the money right to the facility. And we already have the laws. So we only need to implement the laws. We are only 2 years, and we are working to implementing the policies and the laws that are already existing.
Thank you, PS. I'd like to talk a little bit more about implementing the laws, because that seems to be where Kenya seems to have a problem. And I'll come back to you on that. I'd like to jump to Dr. Ndirangu, AMREF. Dr. Ndirangu, you have worked in the healthcare space for a long time, and Kenya has been on this UHC journey for a little over 10 years now. And the decades of effort that you've seen, the coverage still remains elusive for much of not just the Kenyan continent, the African continent. If you expand it beyond Kenya's body, much of the African continent still has a problem with this. So what is the single biggest mistake that Africa is making in trying to implement UHC?
Thank you very much, Zainab, for your passion on this subject and the entire Nation Media Group. And I would like to first of all start by affirming that what Madam P.S. has said is very important.
Your microphone that seems to have, maybe hold it closer to your...
Testing.
Yes, that's better.
Yeah, so once again, thank you very much, Zainab. We admire your passion, the passion of the Nation Media Group on this subject, and also your support to the people of Kenya. I would like to support PS, public health, in that for us to succeed in Africa, there needs to be something called rigorous prioritization. We do not have enough resources for everything. Look, if you go to Europe, North America, the per capita expenditure on health is in the region of 2,000 to 3,000 per person per year.
Shillings or dollars?
Dollars.
Dollars, okay.
But when you come to Kenya, the per capita expenditure on health to Africa is in the average of $100 per person per year. That
So
is
more
something
than
like
10 times
5%.
less.
It's 20 times smaller. Now, when you think of that, we cannot keep replicating or try to replicate models from elsewhere. We have to build our own models based, number one, on rigorous prioritization and to support your peers. Looking at, if you go to a county or a facility, what are the specific needs based on that county? If you go to Wajir or Marsabit or Homabay or Nyeri, where I come from, what are the specific needs that county needs? Is it for newborn care, malaria, or whatever it is? And how do we meet that specific need without wasting any resources? And I think that's where, number one, we have not gotten it right, because generally in Africa, because we try to replicate models, we really need to have home-built models. But allow me to deepen that and say, a few other key issues is political commitment. The countries that have succeeded in this journey, like Rwanda, Ethiopia is on the way to that, Ghana has tried, and now Kenya is making very good progress. The president, all the way, the ministers, all the governors, the chiefs, the GAO, they are all supportive of this. And I think Kenya, we are now seeing that. We have that political commitment. But what we do with it, and thank you, PS, for reading that, is entirely up to us. Allow me to mention 2 or 3 things that could make us succeed. And this is what, generally in Africa, sometimes we get wrong. But let's keep asking, how do we get it right so that we keep positive? And some of those I would like to highlight is, number one, is ensuring community ownership of everything that we are doing, community trust. For example, how do we make sure that the community health promoters, the people in a PCN or in a community unit, fully trust and understand how SHA works? And where things do not work, if, for example, someone goes to the hospital and somehow the bill is not paid or there's a delay, that is quickly addressed. So that's number one, building that community ownership, community scorecards, and driving an agenda whereby SHA and all of us are able to get feedback from communities. It's so important.
So we don't have community ownership right now?
We are headed there. Okay. We have much more work to build community ownership.
Is taking
We're
notes.
headed there. We're headed there. We're doing good.
Yes.
Amazing political commitment. Now we have a journey to build community ownership at the grassroots. That's why GAO is here. Community health promoters are there. That's why Nation Media is here. That's why we are all here. How do we build that?
The community of ownership.
Number 2 is how do we build public confidence? And the key points about public confidence would be, number 1, ensuring that when people look at SHA, the Social Health Authority, they perceive that it's a transparent organization able to deliver the promise. That's number 1. They see it as a highly efficient organization where there's good balance between operational costs and service delivery costs. And number 3, they do not have any questions, for example, related to the means testing tool. When you talk to Wananchi, sometimes you hear that a disabled family was classified that they are supposed to pay so much more in terms of premiums. How do we make sure that quickly we are moving SHA to addressing any teething issues? And let's be honest, it's a new system. PSA is only 2 years. If we keep talking about problems and not pinpointing solutions, the problems and looking for solutions, then we are not helping our country move forward.
Okay.
We find a problem, we look for a solution. And then finally...
Hopefully we'll find those solutions in this room.
Yeah?
Hopefully we'll find those solutions in this room.
We better.
Yes.
Then finally, let me talk about financing. I just talked about that the per capita expenditure on health in Africa is on average $100 per person per year. Government spending is usually about $20 per person per year or thereabout. And then personal contributions and private care financing, that's what brings it, is the other 80 or thereabout. The question is, how do we finance our healthcare with such resources? I don't want to call them limited resources because it's our resources.
Yeah.
If you have a home and you earn 10,000, 20,000, everything, you don't say we are poor. You say, this is what we have. How do we make sure that my children will take eggs and ugali I'll buy maize and millet at the Roco Mill and buy sukuma wiki. I'll even grow some vegetables around and we eat a health. How do we find enough resources? I have 3 ideas to share. Number 1, we're already doing it. Facility Improvement Fund. That's a golden opportunity to move this country forward. To have resources ring-fenced at the primary healthcare level and not used to build bridges or roads, being used to hire that nurse, to buy drugs, to test people for diabetes and all that. Number 2 is the whole idea of improving financing through sin tax. Do you know, if the government wanted, we could raise 15 to 25 billion more shillings per year if we worked to tax alcoholic beverages, tobacco products, and sugar drinks.
Oh, good. So not our pay slips.
And then
not our pay slips.
Yeah?
Not our pay slips.
Not more on our pay slips,
okay.
but more on our beer, on our cigarettes, and the sodas we take.
Okay.
And then reinvest that money. Countries like Botswana and South Africa have done that. And as long as we do that and then use it in a performance-based financing mechanism, prioritizing prevention, there is no reason, absolutely, why we should continue saying we are poor.
Okay, so thankfully we have, the next session will be on healthcare financing, and we'll have representation from SHA in the room. So the questions you have about SHA will be answered. Hopefully they'll be answered in that next session. So I'd like to jump to WHO. Mr. Cosmas, you work from a global perspective, and you've seen other countries around the world try to implement this UHC. He has mentioned Rwanda's success. He has mentioned Ethiopia on the path to success. What would you say is the best model you've seen so far that Kenya could borrow from?
Thank you very much, Nation Media, for inviting us to this platform. As WHO, we recognize that universal health coverage is a journey. And this journey began way back in 2012 when a resolution was made in the United Nations General Assembly on universal health coverage. And that is the day that we as member states do celebrate as UHC coverage, UHC Day. I must say that realizing UHC is a complex process. And we must appreciate the efforts that we have seen in our various member states in moving towards this journey. We recognize that different countries experience different challenges depending on their context, resource availability, and political will. Good enough back home here, we have seen sustained political will. And some may call it political buzz. But remember, since 2012, member states passed resolutions towards accelerating their progress towards UHC. And that journey calls for all of us to come together and work with our respective governments towards this journey. We recognize that countries face different challenges, like has been mentioned by our peers and also our colleague from AMREF Health Africa. Resource constraint has been one of the core challenges. But then that can be addressed in some other innovative ways. The government, as you've heard from our peers, has come up with innovative approaches towards health financing. So as WHO and other global health bodies, we also call for strategic prioritization based on the limited resource that we have. But also, we call for innovation, looking at various innovative approaches that can be employed by our member states toward accelerating progress towards UHC. But then again, the aspect of the political will. And I think that's where, in our context, we talk of political buzz. But I want to mention and just remind us that the concept of UHC, as I mentioned, started way back in 2012, globally. In Kenya, you remember the efforts that the previous government started in 2018 when they piloted UHC in 4 pilot counties. And from that, we learned some lessons. Then come 2022, the new government in place has sustained the efforts. And to do that, we've seen various bold steps that have been made by various governments, not only in Kenya, to ensure that the progress towards UHC is sustained. I want to highlight a few core areas that we as WHO and other global bodies do emphasize to to our member states to ensure that they accelerate progress towards UHC by 2030. 2030 is not far from us, and we realize that based on the global report on UHC that was released in 2023, we take note that a number of countries and the world overall is off track towards achieving UHC by 2030. That underscores the challenges that different countries are experiencing as they make interventions, as they put up interventions and accelerate progress towards UHC. But that should not discourage us as countries towards being more bold, putting in place bold steps towards that journey. And the other thing that I would want to mention that also countries are really employing, and which we've seen also in Kenya, strengthening our health systems. And to do that, and not just making as a policy, we've seen countries such as Kenya, for example, putting in the right legislative frameworks, which goes a long way in institutionalizing the process and getting it out of what we would term as a political buzz, but just ensuring that the gains that has been made, depending on the different government cycles, are sustained moving forward. Lastly, is just to mention that to achieve or to accelerate progress towards UHC, it needs all of us, the media, the private sector, the international bodies such as us, and all partners who are working with who are present in different countries. So that collective responsibility, collective ownership, and also engaging the citizens through media education like we are having now, but also through active public participation to ensure that they have a role in the design and monitoring of UHC implementation.
So there's no specific country that you would say has made significant progress far ahead of everybody else?
There are a number of countries, like what my colleague mentioned. Okay. We've seen progress varying across countries. Kenya, I mean, if you compare with our neighbors, Rwanda, South Africa, even Ethiopia, and other countries within the region, we are seeing varying progress in different countries, but we recognize that countries have got different contexts, and which we need to walk the journey with them together.
So on a scale of 1 to 10, where would you say Kenya is at?
On a scale of 1 to 10, that's an interesting question. Let me answer it differently. One of the key measures that we deploy as WHO in assessing how countries are progressing towards UHC is the UHC Service Coverage Index, which in the context of Kenya, as of the last report that we released in 2023, Kenya was at 53%. So in a scale of 1 to 10, you can see we are almost getting to 6.
Okay. Piesa unaona na smile vizuri. She's very happy with that. She's very happy with that. So Piesa, I know you have a rebuttal, but before we get to you, let's hear from Mr. Maleche. The USA discourse, the UHC discourse itself frequently overlooks the intersectionality of health needs. People usually need a myriad of things at the same time. Rarely will you find somebody just needing one service. So how then do we address the needs of the people who face these multiple layers of marginalization? People in the north who have to walk miles and miles and kilometers before they get to a facility. The people who are economically advantaged, but they need services. So how then do you address all these people who are facing different forms of discrimination?
So thank you, Zainab, for the question, and thank you to the Nation Media Group for having this session and inviting me. My name is Alan Maleche, and I work at KELIN, which is an NGO that focuses on health and human rights and looks at the intersection between law, human rights, and health. So before I get to your question, I just want to say real quickly how we understand UHC is that you're looking at 3 things. One, what services are provided, which ones are paid for, and who's prioritized in getting the services, because at no day will everyone be able to get all health services for free. That is not possible. It requires that prioritization has to be made in terms of which services, who accesses it, and how much is taken care of. And so in the case of working with vulnerable communities, the challenge that we face with UHC is to determine how available are the services, how affordable are the services, how acceptable are the services, and are the services of good quality. And this is a benchmark that is drawn from international guidelines that we have already adopted within our laws and policies that Madam PS has already eloquently spoken about. And so the challenge that comes for us is, with the rollout of universal healthcare coverage in this country, the standard that we hold the national government and county government accountable is to say, how well is a person with disability accessing health services? How well is a person living with HIV accessing services? How well is a refugee who is in Kenya being able to access services? And as you said, people don't live single diseases. You could have HIV, but you have hypertension, you have cancer, and so we want to see then how well is the health system not fragmented, but designed in a way that if you walk into a health facility, you are able to get these services without judgment, without stigma, without discrimination. And discrimination does not only mean being denied services, it could mean that there's a fee that you cannot afford because you're poor, and if there are no barriers to reduce that fee for you and you're not able to access the services, then that becomes a challenge. And so we are concerned then, how do we ensure the rollout of the social health authority functions? How do you ensure that the rollout of social health insurance is working in a way that is putting priority to those who are most vulnerable and those who are most marginalized in the country, in the counties, and the design and the key score for us is that the more you access those who are most vulnerable, the more then your services become more accessible, because if you reach the hardest person, then it means you're doing your best to consider all types of vulnerability. It just goes the same way with the votes. If you're able to get the person in the most remote area to cast their vote, it's the same ideology with healthcare. We need to be thinking who is most vulnerable, who is in the most hardest place to reach, and how are we designing the social health insurance fund to be able to reach that person, because if you reach that person, then you're meeting the goal of healthcare being available, acceptable, affordable, and of good quality. Thank you.
Thank you. But just a quick follow-up on what you just said. If you're able to reach the farthest corner with a vote, why can't you do the same with healthcare? Qua ground, as somebody who's on the ground, what do you think the challenge is for the healthcare?
I think the challenge for healthcare is priority. We all know how elections is prioritized in this country because it's voting that gets us our leaders. And we all know there's always been an emphasis around investing in what we normally call in law, civil and political rights, the rights people feel and touch. And health being a socioeconomic rights are some of the rights governments have not prioritized. And so Kenya is one of the countries that already has an enabling law through the constitution that says you can actually hold your government accountable for not providing the right to health, for not providing the right to education, for not providing housing. So about 12 years or many years down the line of having the constitution, the key question has become, what progress are we making? We would want to see a situation where various governments tell us we found health here and we've moved it from point A to point B, and do so in a transparent manner where citizens, communities can engage and say, indeed, we were paying this for NHIF, now we are paying this for SHA, and this is what we're getting in terms of services. Dialysis has improved, access to ARVs has improved, and we've been moved by government X from point A to point B. And so I think one of the challenges we are facing is measuring that progressive realization. We know every year, every 5 years, elections will happen without fail. Whether there's money or no money, we'll always go to the battle box. Whether there's corona or no corona, we went to the battle, to the ballot stations. And so the question then becomes, for the case of health, how then do we measure this progress? Because you cannot get health immediately for everything. We agree it has a cost. And so the key concern for both the national and county governments is to be able to get the trust of the citizens to say, we came into the government at this level, this is what we found, this is where we want to move you, and every year we are giving you an update of how we are moving you there, and you have the ability to question us. whether we are moving you in the right direction or not moving you. And so dialogues like this become important, but such dialogues should generally emanate from the national and county government to bring the citizens that it provides services together to be able to interrogate, is this actually working for us? And how do we make it better so that at the end of the 5-year regime of this particular government, we then say, indeed, you moved us from point A to point B to be able to get closer to fully realizing the right to health.
Great. So I'd like to open the floor to audience questions. Maybe we can have somebody with a microphone. Do you have another microphone that can be used for the audience?
Before you go, I want to...
Yes, P.S., I was coming to you. I just need to first a microphone to be moving around to get the audience ready, and then we get to you. So the two things I'd like you to respond to, P.S., as you make your statement. I'd like you to say, to first talk about something that Dr. Ndirangu mentioned. Did we copy this model from somebody else, or is it our own model? And what was the rationale behind it? If we copied it from somebody else, what was the rationale behind it? And then I'd also like you to touch on Maleche's point on tunafikisha kura lakini kwa medical services is where we have challenges. What is the challenge there? P.S. You can proceed.
Sorry, come again.
Two things I'd like you to talk about.
Yes.
One, the UHC model that Kenya is currently implementing. Did we copy it from someone, or was it our own model? And if we copied it from someone, what was the rationale behind using that specific model as opposed to any other? And secondly, why it's so hard to get healthcare to every corner of this country if we can get votes, ballot boxes everywhere?
It's a mixture of many, and I'm sure Shah is here, so they are going to come and elaborate many more. So I don't want to preempt what they are carrying for you. But I want to go back to what my colleagues here have said. And let me say, the rolling out of community health promoters was one of the game changer in the achieving universal health coverage. Those far to reach areas, there are even people who do not know whether they are sick or not. But because they can be told whether they have blood pressure or blood sugar, then they are able to respond to the same. And mothers who do not know that prenatal care is very important. But I also want to go back to what we are talking about, community ownership in our rolling out of universal health coverage. In the structure of PHC, the primary health care, every community has a representation in the committees that run the facilities, which is very critical because communities are dynamic. Therefore, you need to actually be the person to say, this is what we need in this facility. And that's a game changer again. I want to talk about public confidence. You saw me writing, yes, because we get notes from people. That's how we improve. I don't know where is that pullout?
We can get another copy. We can get another copy right away.
You know, I said health is a collective responsibility. And when we talk about public confidence, it starts from here. Is this going to convince the public of what we are doing? And just allow me to bash you on this one. Yeah, because it starts from here. It starts from nation conceiving something different from what the masses are expecting. So you have already talked to probably 55 million people. I'm only having a handful here. You have a bigger mouth and a bigger voice. I mean, I think it is only fair if we agreed on the way of communicating to the public to build public confidence. And I said, yes, indeed, there could be some issues that are not okay. But look, there are many other things that we have done right. Can you advocate for the same also? Equally, in the same vigor that you advocate for this one. Hence, we will build public confidence together. Remember, there is nobody called public. It is me and you. And there is no patient for public and private. A patient will be a patient. When they get unwell, it is either your mother or my mother. Therefore, I'm calling out to the media because I have this platform. Let us join hands and build the public confidence. The bad things, we will point them out and we will rectify. But the good things, let us equally advocate for them, like registering to the Social Health Authority.
Thank you. There's somebody in the audience who has a microphone. Please state your name and who you're directing your question to.
Okay, my name is Brian Ochwada. I work with Britam. My question will be directed to Dr. Ndirangu. Dr. Ndirangu, you mentioned that in Africa, the average household expenditure per capita is $100. Now, private insurers create affordable premiums. They create access to affordable healthcare through maybe very, very affordable premiums or through payment plans of installments through insurance premium financing. So are private insurers contributors to that low figure? Or if not, what are the contributors to that low figure of $100?
Okay, thank you. We'll take at least 3 questions before we proceed. Another question? There's a question in the middle here.
Hello, everyone. My name is Melissa Wanda. My question goes to Madam PS. And congratulations for all the work and the efforts that have been done in the health sector. With the new reforms, we see a lot happening there, and even the gaps being tried to be addressed. I'm thinking of sustainability beyond the current administration. One key pillar of sustainability is financing. Beyond the facility improvement financing and the social health insurance, what mechanisms is the government thinking of to reduce disruption of services when there are gaps in financing, like what we currently had with the policy changes? Some of the strategies have been mentioned, syntax. I've not seen a lot of conversations around that in the health sector. I'm just eager to know whether there are any other plans to beef up on the financing front. The second question is on policy implementation. There was a directive that was given to align all policy documents to the government planning cycle. That means all documents end in 2027. I am afraid that there'll be an implementation gap there when it comes to policies, because before an administration settles down and then they're able to then develop new policies, that will take quite some time. So what is the government planning to do if all policy documents are aligned to the planning cycle with that risk of vacuum existing? Thank you.
Okay, another question in this section here. There's a question over there.
Thank you very much for the opportunity. And like the PS saying, that we have to be specific and go specific, I want to go to a specific area that I think that somebody mentioned of marginalization, communities and marginalized areas. I want to talk of a marginalized area as far as illness is concerned. And this is a condition known as lupus.
Okay.
We have the peers, we have the doctors, we have the nation. I want to find out. We have a number of doctors, the rheumatologists in Kenya, about 15, who have worked tirelessly as far as lupus is concerned. Some are in the government institutions and a few and others in the private sector. They have always been together with the lupus patients. Lupus patients normally meet in May when we have the Lupus International Month for Lupus, and there is also an International Day for Lupus Awareness. Those doctors, the rheumatologists, have always been very kind, and they have assisted them. But when it comes to certain areas, we feel marginalized so much, because it is rare that you get a single medicine for a lupus patient in a government institution. Okay. These medicines will only be found in the private hospitals and in chemists and they are too expensive. I know there might be 1 or 2 patients here, and they spend 20, 30, 40,000 shillings per month. It has happened to me. And some of them find it easier to look for money and fly to India when you have the flare-ups, so that you are checked, a kind of an overhaul, and then come back to Kenya with the medicines. Okay. To sit down, I want to request the PS to ensure that there is a census or there is a registry in every county, so that every patient for lupus is known. Because I don't think now, because I'm trying to inquire, nobody can say how many patients we have in Kenya.
With lupus? Okay.
Of lupus, yes.
Okay.
In my group forum, I know we have about 300-400, and in 1 month, you have 1 or 2 dying out of the 400. What about the rest of Kenya?
Thank you. Thank you, sir. The last section, is there a question? We'll take that last question and then we proceed. There's a gentleman over there. So you please state your name and who your question is directed to, and please keep your question short and straight to the point.
Yeah, I'm Andrew Bogi, and my question is, nowadays, you see, I'm an old man, I've seen a lot. Why are we having so many chemists everywhere? What is happening? What is happening?
Okay.
That's question number 1. Question number 2. The community health workers, to me, they are very, very important, more than even a doctor. How much are you paying them? Thank you.
Thank you very much. PS, you'd like to start?
Wow. I think I'll start with your questions. In regards to the chemists, indeed, we are having a crackdown because there could be illegal chemists that have mushroomed overnight. And the practice of over-the-counter medication has become too rampant. And that is why we have AMR, antimicrobial resistance. When people get sick these days, sometimes the drugs don't even work on you because the reliance on over-the-counter medicine is too much with Kenyans. People get a headache, they even know the drug that they prescribe for themselves, and they go and buy that drug. Therefore, we are on a crackdown in regards to the chemists that are mushrooming in the country. We have taken note of that, and in fact, it is in the process. On the issue of community health promotion, for those who know the history of community health promoters, initially they used to be called community health workers. They were just volunteers, and in some areas they were called community health volunteers. They were never paid, not even a cent. It is this government that has come up with a strategy and a framework of paying them a stipend. It is a program that is run between the national government and the county government, and we pay them on a 50-50 basis. 2,500 from the national government, 2,500 from the county government. It is not a salary, it is a stipend. It is some money to say thank you for the work that you have done. And Rome was never built in a day. We have just started. We rolled out this program a year ago. And so far, so good. There are many other things that we are also looking forward to, even their personal welfare. So we are going to get there, my dear. And I'm happy that you brought up that issue. As at this morning, the community health promoters have been able to assess diabetes, 29 million people across the country. And another 19 million people have been assessed for blood pressure. And this is going to continue as long as we are running or we are rolling out the universal health coverage. Back to the sustainability strategies that we are putting in place. One is on integration of health services. No service should be
like an alien. We should be able, I also talked about sharing of healthcare workforce, you know, our digital superhighway that is having most of those areas captured. Public-private partnerships. I'm sitting between my two partners, AMREF and WHO. In fact, for any public health event response that we have done, I have done with these people who are seated with me here. Just the other day, WHO and AMREF, we were at the airport as late as 2 a.m. receiving the drugs for Mpox, 10,700 doses for the country. That is not something small. So, riding on the public-private partnership in the country. Again, domestic resource mobilization. While I was speaking, I said Treasury or the ministry is getting allocated monies that are meant for disaster management, issues to do with public health events, and that is a good move. Again, when you look at SHA, the primary health care fund is funded by the government. The emergency, chronic, and critical illness fund is funded by the government. We only have one fund, SHIF, that is pooled. It's our Harambe. But the rest is funded by government. That is why, even if you go to a public facility, or a private facility, or a faith-based facility, and is a level 2 or a level 3, you're not supposed to pay, because the government is paying claims to those health facilities so that you can be treated. Finally, local manufacturing. Look, during COVID, even if you had money, let me just put it in a nation's perspective. Even if the country had money, we could not access drugs. We did not have anywhere to buy because we did not have any local manufacturer who could get us COVID drugs. Our manufacturers are China, India, US, and in other countries across the globe. What if we have another COVID of the sort? Are we still going to have the money and we cannot get the commodity? So we have to ensure that local manufacturing takes precedence. And even if you go to KEMSA today, we are encouraging local manufacturing, selling products that are manufactured by our people and manufactured in our country. Thank you.
Thank you. Dr. Ndirango, there was a question for you about healthcare financing.
Thank you very much. Ochanda, thank you very much for that question. And allow me to say that when you think about the per capita expenditure, for example, Kenya, the 100 is an average, the $100 per person per year. If you think about Kenya, that would translate to about $90 per person per year, which is about 11,000 shillings. That is the amount of money available from all sources to take care of every person, the 55 billion of us everywhere. That's the amount you have, everyone has, if it was to be divided and distributed. Now, the way it is distributed, for example, for Kenya, the government is about 47%. I think that should be about $240 billion. Out of pocket is about 24%, which is about 122 billion shillings. The other one is, for government is 237 billion shillings. For out of pocket is 122 billion shillings. Donor funding is about 18%, about 93 billion shillings. Private insurance is about 11%, coming to about 54 billion shillings. Both are just numbers, but what insights do we get from them? For example, for government funding, that's what Madam P.S. is saying, that's the money, that part of it is going to the emergency chronic care fund, the primary health care fund, and all these other investments.
And that money can be boosted through Facility Improvement Fund and also sin tax, tobacco, alcoholic beverages, and a lot of other things to keep boosting that contribution by government, as we also ensure that we apply effective financial management systems, like performance-based financing that prioritizes prevention. When you think of $122 billion being out of pocket, a lot of these are the harabes that people do. Some go to India, some do harabes because the insurance could not pay everything. And when you imagine that money, imagine if we build, if we keep to the track, we build a system whereby everyone contributes to the social health insurance fund, including the informal sector, using the graduated premium system so that it's equitable. Do you see this 122 billion, or even half of it, because again you don't want people to spend that much, could actually go towards pooled, the pooled financing, and it could in a big way supporting the long-term financing, health financing for our country. And then for donor funding, about 93 billion shillings. You have seen the current volatility in the development financing landscape. And the question is, those donors who are kind and they are giving money to our country, even AMREF, we are funded by donors. How do we use those funds as catalytic resources to, for example, improve primary care networks, train community health promoters, and build the systems that are needed for the long term? Because that money will not always be there. So it's about looking at the distribution of those financing and asking, how do we work smartly as a country to make our ends meet? Thank you.
Great. So now I'd like to give each of you 30 seconds. Your mic is on.
Someone asked about lupus.
Oh, yes.
I think there was a... Sorry,
a
I
database
forgot
for
to
lupus
answer
patients.
You. Yeah. Please note, we already are working on postgraduate training to ensure we have dermatologists in the country. I think that will help a big deal. Equally, I talked about tariffs that are going to be reviewed in the Social Health Authority. It could be one of those areas that we must focus on so that it can be a package and a share.
Okay. So now I'd like to give each of you 30 seconds to think about one transformative intervention you would implement tomorrow on UHC. If an opportunity arose and you're told you have an opportunity, go. What would be the one transformative thing you would do for UHC? I'd like to start with Alan.
I don't think I've had my 30 seconds to think, but I think 3 transformative things I would do if I had any powers like PS had. 3, because they're all connected. I think the first one would be to ensure that the most marginalized among us in the country are taken into account, and we find a way of designing services and products to reach them in a way that promotes equity and reduces barriers to access to services. The second thing for me would be to promote transparency and accountability on how funds are collected, how funds are used, and how the services reach the people, because by promoting transparency and accountability, you build the trust of the community, and which is the third element, bringing the communities, the public along in this particular journey, because if they feel it is something that is away from them, or is something that is causing them a lot of pain, they will not have the buy-in. So focus on the marginalized, promote transparency and accountability, and ensure you bring communities with you in the process of driving UHC forward.
Thank you. Cosmas?
Sorry about that. And thanks, Maleche, for giving me the 30 seconds to prepare. So I'll take it from the point of our engagement with our member states, including Kenya. What are the transformative ideas that we would propose? So one, we recognize that COVID taught us a lesson. as many countries, you realize that when COVID came, we were caught off guard. So one of the transformative innovations that we need to fully establish within the country is building resilient health systems that is able to address the various shocks and as well as maintaining essential health services in light of public health threats. Secondly, and as WHO, we primarily put a lot of focus in building local capacity. That addresses quite a lot of the drivers and the challenges we see where we have people seeking care abroad because they don't have faith in our local capacity, in our local infrastructure, in our human resource information systems. So strengthening local capacity is one of the key drivers that we would recommend that countries also prioritize. Thirdly is to establish strong data-driven accountability mechanisms. We've seen many countries struggle, especially in monitoring success. And I remember one of the questions that came from the floor is how do we monitor success? How do we know that we are progressing well and we are on the right track? So having strong data-driven systems provides a framework that will enable us as countries to be able to monitor our progress and how far we are doing. Sustainable financing we talked about, and enhancing collaboration with all stakeholders, including the media, as I did mention, the public-private institutions, as well as our international organizations.
Thank you. PS, I'd like to skip you for now so that you go last. So you go with a bang. Now, Dr. Ndirangu, your 30 seconds. What will be your intervention? Use my.
Okay. Thank you, Zainab. And first of all, I support Alan's comment on we must reach the vulnerable. That's a core. And also the comment from WHO on data. We really need to use data to drive our decisions. But allow me to add a few more points. One is we really need to see ourselves as agents of change. Myself, yourself, Nation Media, AMREF, WHO, wherever you are, whoever you are, and the job you're doing, it is us to make this succeed, our country succeed or not succeed. How do we see ourselves as agents of change, agents of transformation, and troubleshooting when we see things are not working? And to keep asking for better models. And that's what we call adaptive leadership. That's what you take. Nobody will come to rescue us. It's us here in Africa, here in Kenya, to rescue ourselves and move our countries forward. Number two is we must shift in a big way to a prevention-centered health system. We're already doing that in Kenya with 107,000 community health promoters. More than 1 million people now screened for diabetes and high blood pressure and entering into chronic care. That's huge because we will never, allow me to quote our group CEO, Gedeji Gitahi, we will never be able to fund ourselves out of illness, but we can afford to fund ourselves towards healthcare. When we have so many complications, diabetes, high blood pressure, strokes, dialysis, ultimately we can't afford. We must prevent. And that's why we're talking of PCNs, CHPs. The third thing we talked about it, working to make sure we're building public confidence, trust at all levels, community engagement, that's critical. And finally, funding smartly. Let's remember that our resources are about, for Kenya, it's $90 per person per year. It's about 11,000 shillings. How can we keep expanding that through additional mechanisms like sin taxes and all that? Thank you.
PS, lastly.
I'll say what I'm doing, not what I can do. Because I'm already there.
Okay.
And one of the things is to strengthen the primary health care, and especially the infrastructure around it. Remember, PHC is the foundation for UHC. So strengthening it to be able to have early diagnosis, disease prevention, early detection, community-based care is very, very important. And how to do this is to ensure we also expand and equip the facilities, the health centers. And we are not planning to do it, we are doing it. Equally, there is also expansion of the health insurance. We already have SHA. We are implementing it to ensure that it reaches to everybody. And I love using the word accessible, available, affordable, and acceptable quality healthcare. Because we must access it, it must be available. When you go to the facility, you must find services. Acceptability, we are talking about the public, the community, owning the program, and equally affordability of the same. That is why we are paying for the indigents. And finally, public confidence. That is why we will not have this again. We must be able to create better stories for the people, at least for the health sector. We must also not politicize issues to do with health. We don't have a patient for the public, the patient for the county, patient for the national government, or patient for private sector. Therefore, I'm asking for all of us to join hands so that we can make this country better. Thank you.
Thank you very much, PS. Thank you, lady and gentlemen who've taken your time to join us in this conversation. I know many of you still have questions, but I promise you they'll still be around. You can still ask your questions afterwards, but we have to close this session. We are now going to take a 15-minute break. There's exhibitions in the tent behind us. As I'd mentioned, there's an exhibition in the tent behind us. You can walk through, have a chat with the healthcare providers over there, get screened for some of the illnesses they're screening for. They're also screening for HIV and diabetes. Thank you very much. Now, before you go, please step forward for a group photo. Monica, you'll join us. Sogoti, are you in the room? James Sogoti? James Sogoti, are you in the room? Please come up here. Kinya Gitonga. Okay. Max, come. Kenya, enda uongeze mademu ko. Enda uongeze mademu ko. Camera lens. Oh, Kenya, come down. Thank you so much for coming. Thank you. That's all right. With Monica. Okay. For the panelists, your tea will be in the VIP tent, which is behind us here. You'll find somebody who will show you. Everyone else, I think there's tea. I need to find out where that tea is. So you can walk through the exhibitions and then be back here at 11:30 for the next session.
We follow Mercy. Only 5 books. And then you.
So we are going to see about 5 books. So this is where the exhibition areas, the free services. Because it's
Good late morning to you all, and thank you for joining us on this third edition of the Nation Health Summit, which is happening at the Kenyatta International Convention Center in the capital city, that is Nairobi. And this year's theme is Towards a Healthier Population, Innovating to Accelerate Achievement of Universal Health Coverage. And for the benefit of everyone, we are live on NTV's streaming platforms. And my name is Dan Mwangi. I'm the lead editor, Broadcast Platforms, and I shall be your moderator for the coming panel discussion. And my panel discussion is themed Health Financing for UHC, Achieving Financial Sustainability and Equity. And I shall be having our panel discussion will have a key focus on domestic funding, donor dependency, public-private partnerships, and innovative financing mechanisms. And I shall have 4 panelists who will be joining me on stage. But before I invite them, I would like to invite Dr. Samuel Kinyanjui, who's the country director, AIDS Healthcare Foundation. And he is going to be giving us a short presentation before we get into our panel discussion. Daktari, karibu sana. Let's appreciate him as he comes up. And just for housekeeping, I request that we keep our phones on silent. And if you need to walk out, if you really, really have to walk out, for whatever reason, kindly mind the cameras so that we don't block the view. Thank you, Daktari.
Asante sana. So, good morning, team. Senior colleagues in this forum, professionals, clients, and other stakeholders. I'd like to just take a few minutes, and my whole idea here is that I'd like to look at this topic, particularly looking at strengthening the health systems for outcomes, client satisfaction, and efficiency. I know a lot of the time we spend time talking about where is the money, leaving a lot of space on what we are doing with the money and what it can be used for. And I'd like to my presentation would go towards this direction more than just looking at where's the money. I know my fellow panelists will be able to cover this section. And so I decided to leave that where their strongest points are, so that I focus on something that is most of the time neglected. So, I'm looking at this one as a transforming healthcare systems from what it is right now, which is an input-based system, to an outcome-driven, patient-centered, and financially sustainable. I'd like to look at 5 strategic reform and bold innovations that I'd like to present to you today. And so I'm trying to start with our background. What is the context of healthcare in Kenya today? First, we know that's very low insurance uptake. Very low. I don't think there is much difference between NHIF and SHA for now. Only that SHA has gotten more people register. But I think in terms of payments, my colleagues will let us know about that, is that almost the same people who are paying NHIF are paying now. So that is not where we want to be. We want to go higher. High out of pocket. I'm told about 24% of all our payments is still out of pocket. So this threatens and doesn't protect, like UHC is supposed to protect the households and the communities. Weak measurements of outcomes. I stand here and pause because I do not know, except from vertical programs, I do not know of any other health system mechanism that have a clear, deliberate, well-structured mechanism for measuring outcomes. And that's what is really critically missing. And that's why our providers, a lot of the time, end up competing on the hospital, on the entertainment side of things, rather than the medical aspect of care. We'll get to that. Then we have fragmented the governance. With the 48 governments in Kenya right now, you find that like with the disruption that came about, you find that there are instructions that are varying as you move from across the counties, and even sometimes, even within the counties, you find different hospitals operating from different policy. Misaligned incentives. This is a key one. If my payment, if my income depends on you being sick, can I make you better? I won't explain that statement. I'll leave it there. Limited patient voice. Look at all our indicators. Patients may be screaming everywhere, but we have no concerted system for collecting patients' response, feedback, in a way that it can be analyzed and published. Strategic vision. Looking forward, this is my dream for our country, that we would have an accountable, inclusive, and outcome-focused health system that maximizes every shilling spent to accelerate UHC for a healthier population. I'd like us to shift from thinking about treatment, about services, about procedures, towards wellness, toward healthier. If we do mind shift in terms of that, then it will inform how we think. Because the goal is very important. Like we're saying, we're fighting poverty or we are looking to become wealthy. It's a very big difference. Looking to provide services and looking to make our population healthier. It's a very big mind shift. So, there are 4 strategic areas that I'd like us to look at. And one of them is the leadership. The national and county coordination need to work and build trust. Because the biggest challenge you're having with SHA, we had with NHIF, is not affordability for Kenyans. I doubt that. I believe there are more Kenyans who can afford than the ones who are paying. The big elephant in the room is trust. Do they trust that if they put in their money here, when the hour comes, they will get the services they need? Somebody will be out there looking out for their household, for their children. They don't trust. And therefore, they only pay when they have a problem. And once the problem goes away, they stop paying. Strategic purchasing. It does not matter how much money we have if we end up buying the things that don't matter to our clients. They won't feel us, and they won't trust us, and they will continue to behave the same way. So we must be able to pay for what matters to the clients. I don't think anyone pays to be operated. They pay to get well, to know what's their diagnosis, what the problem I'm suffering from, and how do I get better. And finally, how do I avoid getting this condition or this situation again? Digitization. I think in this day and age, if you are not digital, young people tell me whatever I'm talking to them is not on the phone, then they don't know what I'm talking about. So for digitization in healthcare is special. A lot of patients have been harmed, got complication, and some of them prematurely died because our communication as healthcare workers was not adequate. We are famed for bad handwriting. So that handwriting may have caused many people to be injured. And I stand here as a father of a 19-year-old child living with cerebral palsy because somebody's handwriting, one of my colleagues' handwriting caused that. They were given an excessive dose of some treatment that caused them problems. He is not the only one. Thousands, today, yesterday, and in future, if we don't digitize so that the communication are crystal clear. And there are many benefits of digitization, including tracking, including fighting fraud. I can go on until the cows come. Outcome measurement. If it wasn't done, if it wasn't written, if it wasn't measured, it did not happen. So how many people living with diabetes are there in Kenya? Nobody knows. Hypertension, nobody knows. Asthma, nobody knows. A senior citizen stood here and told us about lupus. He only knows about 4,000. How many more out there? Nobody knows. How can we plan, buy commodities, provide healthcare workers for an unknown number of party or party participants. If we don't know how many they are, we don't know where they are, how can we ever serve them? It's impossible. So we must digitize, register them, know where they are, then measure outcomes. When you start measuring outcomes, and I want to give just one example, for HIV, which is the field where I work, TB and HIV. 2004, 2005, no one was measuring outcomes for HIV. They were even wondering, what do you measure for chronic illness? But the moment we started measuring how many people have been registered, how many have been retained towards the end of the year, that was the first measure we put. Then CD4 counts was the next one we do, to watch how many of them CD4 counts are raising, showing their immunity is growing stronger. Viral load. Then everything is transformed. All our facilities are performing over 80% in all these indicators. Beautiful. How many of us knows how many of people treated for malaria got cured? No one knows. Because no one tracks it. How many of our mothers who got babies are well 10 days later or so on? No one is tracking it. So no one knows. How many people are treated for pneumonia who got well on the first treatment? They did not seek treatment in another facility and another one. Nobody knows. There is one indicator that I'd like all of us who are here to just check. Simple in the DHIS. KIS for now. Retreatment. People who are called reattendant. They work here over the last 3 or 4 weeks, not more than a month, and they've come back with same or similar complaints. Give you a guess. How many are they who come to the facilities every day? Most of the places, they are more than 40%. Those are people who are treated, they did not get cured. Why? Maybe we missed the diagnosis, maybe the treatment wasn't right, maybe they didn't buy the dawa, or they didn't take it as guided. All the same is that we failed. But if we never measure, we will never know, it will never improve. Patient and community empowerment. This party is about who? It is the communities, it's our societies. If they are not, they don't trust it, they will not come, they will not consume. Even when you give them medication, they may not even take it. So we must do everything possible to build the trust so that they can fund it, they can use it in the right way. And we can see benefit as a community, as a country. So what would be our expected, maybe I've moved too quickly. Yes. Now, what am I proposing we do? I am proposing we do the following. 1, we have a national health, electronic health records, standards. Not a tool, a standard, so that all of us can conform to that standard. The government can have a central one, but everybody else, for them to practice here, they should conform to the standard. We should have a package of data that is shared every 24 hours. You cannot decide to drive on the right side of the roads in Kenya. It is illegal. So the same thing for healthcare. We should have a standard of how we do business. All other EHR, EMRs that are not conforming to these standards, government should outlaw them. Give people a grace period to conform, but we should be able to conform so that if it's people in share, they say this is the way. And this is the package that we need so that data portability become a reality in this country. Patient registration and provider network assignment. If you drop now, sick, here, who's responsible for you? No one. If you die outside the hospital, we've seen cases, mothers delivering outside a hospital gate. Who's asked? The hospital say, oh, it wasn't ours, he wasn't in our hospital. Whose responsibility is that mother? If you had registered patient and assigned them specifically to a given network, specifically by name and contact, then we have one individual to ask, the management of that network. And they would invest more in prevention for such a population because it's their hard that they are managing, rather than now when we have left people for anyone. Value-based care. We need to be able to pay for results, for outcomes that matter to the patient. Now, the results that matter to the patient, all the clients I've ever seen in my life, they had 3 questions. Number 1, doctor, what is my problem? What is ailing me? Why am I having these symptoms? They want a diagnosis. Number 2, they want to know Now that the problem is known, how do I get better? Is it a treatment? Is it a procedure? And finally, number 3, which is hardly never answered, how do I protect myself or my child from ever getting sick like this again? That question is never answered. We need to do that. Value-based adjusted capitation. It cannot be a blanket capitation. It has to be risk-adjusted. Then performance bonuses so that the sluggards are left in the doldrums. The guys who are doing a good job, they get a bonus out of it. Right now, we all get the same cut, so there's no point in being smart or being better. Just do the minimum, because that's what makes the bottom end work. Annual Health Outcomes Summit. I propose something like this one, annually, where the minister comes here, or the PS, senior government officers, and list good performance in the market, providers who have met certain defined outcomes, so that others can emulate. Not to punish them, but to emulate, to encourage the others to join the league of the egos. They stop being duckling. To stay away from mediocre practices, okay? Reframe MOH roles. Focus on the regulation and stewardship. Sometimes I feel that the national government unfairly and unduly interferes with the implementation. And I'm saying this having worked in a county. The implementation at the county level. The operation, the mechanics of those things, they should be left to the counties, to the owners of private facilities, to the owners of faith-based facility. National government should just focus on, as the Constitution guides them, regulation, training, financing, and policing. Because most of the time they've forgotten about the policing. PS was here and told us there are a lot of mushroomed, chemists. Why they mushroom? Because the police was way busy in implementation or something else, caught in other things. Focus on that, so that there is a segregation of the referee of the industry and the players in the industry. Because right now, the ministry tends to be the referee and an actor in the industry. And therefore, it becomes difficult to shoot your own foot. Because if the facility belongs to MOH, will they treat it the same way they walked into a facility that's privately owned? The answer is no. So where will we be in 2028 if we walk this road? You can see Mwangi standing. I'm on almost my last slide. We expect that the patient satisfaction level will be at 85, 80 or above. Right now, I think it's somewhere around 30%. NCDs controlled, diabetes or hypertension, at least 70%. Maternal deaths needs to reduce from the highs of 300 we have down to 100. Performance-based budget need to increase from, I don't know what percentage it is now, at least 30% of us should go to performance-based financing to encourage people to walk that road. Out of pocket need to drop by 10% from the 24 to at least 14%. This is protection for our population. So these are next steps that I'm proposing. The national government and COG need to endorse this approach so that it can get the political will that is required. Create a national health reform task force. People who will, this is their daily job, do it, and make sure that we have indicators we can track. Develop implementation roadmap, mobilize the resources. Launch this one as a phase 1 in 3 counties. I prefer the counties that are already forward looking and implementing. I know Murang'a has been quoted in many places. I would recommend the same, among others. And then in conclusion, Kenyans must shift from paying for services to paying for results. The results that matter to our clients, to our patients. With the strong leadership and digital innovation, we have all the laws that we need. Timely payment for providers. This strategy will restore trust and accelerate UHC. Ndugu zangu, ningependa nikomee hapo and say, let me jump this one, you may be seeing it there. Because the clinical outcomes, cost effectiveness, and patient experience are the 3 things that I consider very important. Those are the 3 goals. If you can't hit any of them, clinical outcome most of the time is not monitored because the patient can't monitor that. Cost effectiveness, they can because they know how hard their pocket will hit. Patient experience, no one listens. I should be pointing it this side. So thank you very much. I ended by quoting something I adopted from WHO, that health financing is not just an economic choice, it is a moral one. And the path to UHC must be paved with equity, sustainability, by collective commitment. All of us involved, but some of us have greater responsibilities because we're in leadership position. Asanteni sana. Thank you very much.
Thank you very much. No problem. Actually, I will request you to just stay on stage. You can have a seat. We are going to get into our panel discussion now, and as you can see, you already have one of my panelists on stage. That is Dr. Samuel Kinyanjui, the Country Director of the AIDS Healthcare Foundation. I am going to also invite Dr. Samson Kuhora, who is, let me make sure I get his title, Head of Planning and Linkages at the Social Health Authority, that's SHA, Karibu Sana. I also have Dr. Brian Lishenga. He's the National Chairman of the Rural and Urban Private Hospital Association, that's RUFA, Karibu Sana. Just have your seats. And then I will also invite Dr. Samuel, he's here, sorry, and Kiprono Chepkok, who is the Head of Partnerships at the Kenya Blood Transfusion and Transplant Services. That's KBTTS. Karibu Sana. You could take the seat on that end. I'll request for help with bringing down the podium. All right. I'll request we just check our mics to be safe. Then if you could. All right, the mics are good. Welcome, gentlemen, and welcome to everyone to this conversation, and for the benefit of ensuring everyone is on the same page of the same book at the same time. This panel discussion is on health financing for UHC, achieving financial stability and equity. And our key focus here is domestic funding, donor dependency, public-private partnerships, and innovative financing mechanisms. And, sorry? Yes, I will just mention that when we had reached out to the various other potential panelists, they were unavailable. It was not due to lack of the effort to do so. It was by virtue of circumstance. But thank you for raising it. So I'll begin with Dr. Samson, who is Kuhora, Head of Planning and Linkages at SHA. And guys, SHA is one of the most topical organizations in this country. And just to point out, Dr. Kuhora is not a politician, so he's more of the technical guy. So we are not going to be delving into the politics of this, but the technical dynamics of SHA and financing of healthcare. So maybe you could tell us, in as far as what is the data showing us the status of SHA when it comes to those who are registered, just around that, the dynamics around that, for us to set context.
Okay, thank you for the question, and I would want to give a perspective on the key deliverables for the authority and what we've achieved so far in terms of these deliverables. One of them is around the pillar of access, and access, we are looking at the membership. And when we look at the membership from a financing context, it's not just about the registration, but also the active contributions. So in this particular pillar, we are looking at registrations of about 17 million, almost 18 million now, because 17 was at the beginning of the month, with the formal sector being about 2.4 million, and the rest being the informal sector, about 13 million. Now, when it comes to retention, the formal sector is not a big headache, if I may put it that way. But the informal sector is where the support is really needed. And this is not a country-specific challenge. It's actually something that is a challenge across low and middle income countries that are trying to roll out the universal health coverage. Now, of the 13 million or thereabout in the informal sector, as per the legal requirements, there is a proximis testing. And I think it's been explained in several other forums what the PMT or the proximis testing or the means testing is meant to achieve. So about 5 million have done the proximis testing, and of that 5 million, about 1.4 million have made at least one contribution. So this presents the challenge that we have with the informal sector. Of the 13 million who have registered, just about 10% of that has made one contribution. And that's where our challenge is.
All right, and so that we don't lose that train of thought, what needs to be done to bring in the 90% of the 13 million registered people in the informal space to become part of this? What needs to be done?
Okay, thank you. I'll start with what is broadly known, because when we look at the figures, there are indications that the proximis testing may be actually a barrier, because just about a third of the population registered has gone the next step of doing the proximis testing that is supposed to give them the estimated premiums. So a relook of how the estimated premiums are done for the informal sector would actually make a difference. The other bit is, how do we address the individuals who've gone through the testing but have not been able to make a contribution? Is there a challenge in that? Now, there are several ways of approaching it. One is by using aggregators. Aggregators in our setting are around SACCOs, which can be able to support their membership to be able to make the contributions. The other bit is to look at where does the majority of this population draw their income from. A good number of them are in what we call seasonal income brackets. They are in farming, or they are in such activities where you don't get regular income. So in such a case, having these members in aggregators like SACCO, which can be able to pay their premiums and then they recover from the eventual income that is going to be seasonal, would make a difference. The third bit is, what is the role of AI? I think in all our operating environments, AI is becoming pretty relevant. So one of the suggestions that is there is to have wallets. Wallets which can be able to collect an amount every day. It's basically an app that, based on what you accept, it can be able to collect an amount every other day, and at the end of the month makes a remission on your behalf as a premium. So we are looking at those as solutions that can be able to do that. Of course, there is the aspect of insurance premium financing, which is under negotiation at the moment, but then there are several other dynamics that need to be addressed with the banks that are likely to do that. Then it will be a product available to the public that basically pays the premium for you and recovers it over time. So basically coming up with some of those financing solutions, because we understand the dynamics of the informal sector, would make a difference. And I think one key thing that my colleague mentioned earlier, this is a business of trust. And one of the key things to achieve, because you might have all the solutions, but if the trust is not there, somebody will not take the next step to do that. We need to basically build that trust, and there are several ways in which that can be done.
All right, thank you very much, Dr. Ari. And Dr. Lishenga, I'd like to bring you in. Dr. Lishenga is the national chairman of the Rural and Urban Private Hospitals Association, that's RUFA. And in the spirit of status update, what's the current status of our private hospitals, especially those under RUFA, when it comes to the finances? And I know there have been concerns about non-payment from the government, etc. What's the current status?
Okay, thank you so much, Dan and colleagues. I am happy to be here. Now, I think what I can say ties into what Kuhora has said. One, I think maybe those here, members of the delegates here, might remember that RUFA issued a statement of withdrawal of services sometime in late February because of non-payment of NHIF arrears and other challenges we have had with the transition from NHIF to SHA. Now, so where are we right now? I would say that, one, the NHIF arrears have not been sorted out, and for context, that was about 33 billion Kenya shillings, which was owed to hospitals by the defunct NHIF. Sometimes people don't understand where, you know, when I talk to members of the public, they ask me, so we were making contributions. When you transitioned from NHIF to SHA, wasn't there money in the account? Where was our contributions going? It's a little bit more complex than that. Part of it was they were what we call enhanced schemes within NHIF. Enhanced schemes include things like police schemes, teacher schemes, schemes for civil servants, Linda Mama, schemes for the elderly, orphans. Those were schemes which the money for paying for care under those schemes was coming from third-party organizations, not individual contributions. So, for instance, for Linda Mama, this was a Ministry of Health budget. For orphans, vulnerable, and elderly, Ministry of Health budget. So, when you look at the breakdown, that amount of money that wasn't paid to healthcare facilities, but they did provide care, that was owed to healthcare facilities by government agencies or, you know, semi-autonomous agencies like the Police Service Commission, the Teacher Service Commission. So the point is, when we transitioned, in reality, ordinary Kenyans who make contributions from their salary or voluntarily, they were in general making contributions. The problem was state agencies were not keeping their end of the bargain. So the question will be that if police officers were getting care, if teachers were getting care, if civil servants were getting care, who was paying for the care? You and I were paying for that care from our contributions, but that would result in a deficit. So you basically kick the can down the road. So that's how we ended up with 33 billion. Now, what is the connection between the 33 billion and care? It's very simple. Hospitals had gone for many months without, for instance, paying salaries. So you have nurses, you have clinical officers, you have doctors, you have your cleaners, you have administrative staff, who, because you are in a cash-strained position, you have not paid salaries. And these are very common stories. So the other part was layoffs. There were a lot of layoffs because, I mean, if you need to balance between paying rent, paying power, paying for water, and you have a payroll cost, then you rationalize. So people lost jobs. So, but more critical for patients is that you would go to a hospital and maybe not find the service that you require. No drugs, okay, no equipment, and this was because of all the financial strain. And this was what was making part of what was contributing to the transition being extremely unpopular. And what I'm saying is not only tied to private hospitals. This is not a private hospital experience, a public hospital experience. Any of you who has gone to a public hospital, you find no drugs, no nurses, all this. The question is, so why? What is happening behind? The problem is financing. So it was a cross-cutting issue. Now let's talk about the Social Health Authority. So for the Social Health Authority, the initial problems around claims and disbursement of money were technical issues. The SHA portal was not working. In fact, we went for most of October last year without a portal, functional portal. And for the first 2 weeks of the transition, we submitted manual claims, paper claims. Now, to this day, as we are here, those paper claims haven't been processed for many reasons, one of them being NHIF had 1,800 staff in branches across Kenya and headquarters. SHA intends to reduce that number to 800 only. So 1,000 people are going to get laid off. These 1,000 people do, obviously, honestly, they will not look at paper claims if you have no job security. So that is also an issue there. So after October, through December, November and December, there were a lot of attempts to stabilize the SHA portal. In fact, your registration experience, the fact that you go to hospital and your details are not available, your dependents are not available, the one-time PIN delays, those were all issues. Now, so that was technical issues. The other issue was the funding model. So under NHIF, hospitals would be paid X amount of money as a prepayment for Y amount of people, Y number of people. So, for instance, my hospital, if it has 1,000 Kenyans who have selected my hospital as the hospital for outpatient services, I would be paid per quarter in advance 300 shillings per person. So that is roughly, it varied depending on level, but in essence, let's use 300 shillings. 300 shillings times 1,000 per quarter. 300,000 shillings to provide care for these 1,000 people, regardless of how they show up. So whatever they show up, I provide care. So that was the outpatient capitation model. When we moved to SHA, there was a move by the Ministry of Health, the government, to change that model into what we call global budget payment. Very complex model. I don't think I have time to explain it. But in essence, how many people are registered in Nairobi County under SHA? So let's say 600,000 people in Nairobi County are registered. The budget for outpatient in Nairobi County, outpatient under SHA, is 600,000 people times 75 bob per month. That is 45 million shillings per month for Nairobi County for outpatient. Then you have to decide how many primary healthcare hospitals are in Nairobi, how many patients did they see, what conditions did they have. That model was not in place. So what happened? Hospitals, because they were not sure of how they will be paid, whether they will be paid, they stopped providing outpatient services, and that made SHA very unpopular. Where are we today? We are in a situation where the primary healthcare model getting somewhere, but we hear providers saying, I cannot predict my revenue. This month I get 100K, next month I get 1 million, the other month I get 500K, next month I get 0. And the whole formula is a well-guarded secret somewhere in, I don't know whether Quora knows where it is, but it is a well-guarded secret somewhere. So that is still creating uncertainty. Today morning, we had some payments going out from SHA for SHA claims to hospitals. We have been monitoring our members. They are getting about 25% of all their claims paid. So these hospitals are under dire distress. Now, what I have a challenge with is the posture taken by government and by ministry that anyone who points out something wrong with the model or is an enemy of development and a beneficiary of NHIF cartels. We really need to go away from that. Thank you.
All right. And just for clarity, those must be hospital on. And just for clarity, you spoke about initially the systems were not working, etc. Just in terms of that, are we okay now?
Okay, I'm on national TV.
In all fairness.
No, we are not okay.
So assume we're not on TV.
We are definitely better than November, October, December last year, but we still have intractable issues. Let me give you one that will touch patients directly. So for now, surgical claims have not been settled to a large extent because they are under something called clinical review. So they are trying to find out whether it was fraudulent or not. But, they are trying to use AI and all these things. That system is not ready. So the net effect of that is if you go to hospital today for surgery, you are likely to be asked for cash payment because we have hospitals that haven't been paid for surgeries they submitted in November last year. Why would they trust that when they submit in March or May this year they will be paid? So to protect themselves, they are asking people to pay out of pocket. So we still have issues that need to be sorted out, and they are intractable.
Okay, thank you very much, Dr. I want to come in to bring in Kiprono Chepkok, the head of partnerships at the Kenya Blood Transfusion and Transplant Services, KBTTS. Again, we begin like social media status update. What is the status of our blood banks? Are our coffers empty?
Thank you, Maina, for this. We can say we are there, but we are not fulfilling 800%. Why are we saying this? The WHO guidelines gives us that at any given time, we should donate blood which is required for transfusion is 1% of the total population. That is at the lowest. We did a study which ended last year, and we have found that in Kenya, we require up to 3% of the total population. If we take our population right now at around 55 million, it means that per year we require a minimum of 550,000 pints of blood. We can say we have progressed in the collection of blood. The last financial year we collected, that is 2023-24, we collected 450,000 pints, against what we are targeting at 500,000. meaning that we still have a deficit of more than around 20%, which we are not meeting at right now. But allow me to say something, that blood is we call it is a drug. But this drug we cannot manufacture. We have to get from people. The problem with us Kenyan is our donation culture. We rarely donate. And the way we have always told you people that you can donate up to 3 to 4 times in a year. As a lady, you can donate 3 times, a man can donate 4 times. That means after every 3 months, we can donate. If all Kenyans can donate at least once in a year, it means that our banks will be enough. So I can say we have a problem with our donation culture. We are not badly off, but we are around 80 to 85% of the total need.
Okay, just before we move on to Dr. Kinyanjui, I was reading an opinion on health policy by Dr. Peter Maturi. He's a senior lecturer and chairman of the Department of Human Pathology at the University of Nairobi. And one of the things he raises is that, and I'll read, according to the Ministry of Health, Kenya collects just 450,000 units of blood annually, far below the estimated national demand of 600,000 units. Shockingly, over 60% is by students, and 30% of donations are from family replacement, not voluntary contributors. He says this system is not only inadequate, it is inequitable and dangerous. So when we talk about students, is this the ones, I remember when I was in high school many years ago, the big guys would come for blood donation, then we'd get sodas. So some of us were going for the soda. Those who were in boarding school, wale wenye mulikuwa shule za kifahari, you're excused. But maybe just speak to that in terms of you're seeing more students and not as many people who are willing.
Thank you for that. I think, let me say that blood was because of bread and a soda. We can always attest to that. Our donation age is always between 16 to 65 years. Even when we go to the secondary school, we'll always take around Form 3 and Form 4s who are there. Our donation culture in high school is always high. As we go to the tertiary institution, the curve comes down. By the time we are out of the institutions, we rarely donate unless when we have a patient in hospital. That's why we always get a lot of these, what we call the campaigns, telling people we have somebody come and donate. We want to say that we are discouraging family replacement. Why are we discouraging this? This is not volunteer donors, they are risky donors. When you are a volunteer donor, we have a questionnaire. And in that questionnaire, we'll ask a lot of things. For example, right now we can tell you, when was the last time you had a medication? When was the last time you had probably a risky behavior, sexual behavior with a known person? It is part of the safety we want to give in that blood. But the moment you have that family replacement, you are the 3 brothers and you have your mother there, and we say, let's go and donate. You will not say that I had a risky behavior yesterday. It will be very risky for us. So we want to move out and say that people, can we be voluntary regular donors? If we do that one, we are going to have, we can change the tide from that 30% to 100%. We want to say thank you to a county like Taita Taveta. Taita Taveta right now, the volunteer donors, they are more than 90%. The family replacement is less than 10%. But when you go to Kenyatta National Hospital, when you go to the private institution, it's all about family replacement. But we want to see, and it is good that you have called us today, so that this can be another way of sensitizing the public and tell people that when you donate blood, it has no side effect. You can always donate. Our highest donor right now is around 115 pints, and he's living well. The highest lady right now is almost 100. Is 100. She has donated 100 times. Aisha Dafala. She has no medical condition. Can we queue and make sure that every 3 months and 4 months we come and donate blood?
Thank you very much. Challenge has been thrown to you. There's someone who has done it 115 times. Some of us are ready to get 1. We are still on the queue, so that's a great challenge. Dr. Kinyanjui, and you had initially spoken to some of the issues here. regarding the space you work in as the country director of AIDS Healthcare Foundation. And as we now, because you had already set the stage in terms of the status update, right? When you're now starting about the funding, okay? How can, for example, the organization and similar ones in the health space get funding but not be overly dependent on donors? Because that's one of the headaches that we have. And I'll also just have the rest of the panelists also feel they would chime into this. How do we have funding that is not so dependent on donors that when Trump does his thing, we are not in a crisis with health? How do you go about that?
So thank you very much, Dan. First, I'd like to say that AIDS Healthcare Foundation, by design, is designed in a way that is sustainable, as in it operates a business model that has both income-generating arm and a social arm. So most of the work that we do in a country like Kenya is mainly the social arm that is benefiting from the other functions, clinics, pharmacies, thrift shop, and cafes and low-cost houses that make money for the AHF. So that's a mechanism that has made AHF 38 years of existence very sustainable, because we generate like 90% of the operating cash flow. So I think for NGOs, that is also a mechanism, rather than depending on 100% of the activities being funded by a donor, 1 or 2 donors. We can also engage in activities like the way mission hospitals are implemented. Most mission hospitals also run on a social marketing kind of approach. Their rates are much lower than the market rates. Their markups are limited. And because they do not declare profit, then most of the money they make is plowed back to make sure that the organization is sustained, services are quality, but the rates, their fees are still manageable. In addition to this, what I'd like to say is that beyond the organizations themselves, the FBOs and other implementers in this space, I think the biggest challenge, the shocker that we got as a country, is because I think the Ministry of Health completely, and I'd say this extends to the county government, completely neglected the HIV, TB, family planning, immunization, and depended almost 100% on donors, or not investing. For TB, I would say the Kenya government in the region stands ahead of the others, way ahead of the others, because the government buys all the drugs that are used for adult treatment, but treatment for children is still donor dependent. And one of the issues here, and I'm happy I'm flanked by very powerful people here who knows the details, I do not fathom why patients living with HIV infection, which is a chronic illness once it's been stabilized, TB, family planning, were excluded in the benefit package of a national social health insurance. How is that possible? That you leave 1.4 million people out, yet many of them are contributors to the fund. They contribute, but they are excluded. And we pressured and pressured the ministry. They said, no, they're included, no, they're included. But when the tariff came out, they excluded. So the first thing and the first request I'd like to make here is that the first thing that to respond to what happened in the donor community is, say, initially we were told is because you're getting a lot of money from donors, okay? Now the money from donor has gone. Can we get the people living with HIV included in the chronic care package? It will only take 4,800. It's about 6 point something billion. And if you do this, people living with HIV infection, TB, they will also enjoy the same services as people living who have diabetes, who have hypertension, and the hospitals will stop discriminating against us. Because what happens is that everybody else is queued, And when it started, I went to Western, and people were being told, SHA, by the way, was by force in most of the counties that are leading. You could not get services. And this is my personal experience. You could not get services. I won't name the counties, because this is not a name and shame. It doesn't help. Some counties were saying, you will not get services for anything. You have to pass through the SHA desk and come with the show that you have registered. So most people feel coerced. Now, the coercion does not promote trust. It only gets people angry, and they rebel. So, and I'm happy with you talking about aggregators. I'd like you to add the members of the providers. We as communities trust the providers a lot. Why are you not asking our providers to be aggregators? They can be very good aggregators, right? Yes. We trust our doctor, we trust our nurses. That's why we go when we are in trouble. We trust them. We remove all our clothes so that they can see everything. So if they guide us that this is a good way, it will be a winning combination. But we also need to make sure that you're paying them on good time. So that is the catch-22. We need to pay them on good time, but more importantly, we need to use the people who, you cannot buy trust, but you can borrow trust from those who already have trust. So that's the perspective I have. But the first thing we need is to make sure this is universal. Let's have no one left out, deliberately left out. Then the other thing, how can you trust me if you're hiding the formula? How can I trust you if you're hiding the formula? Thank you very much.
Sawa, thank you very much. Dr. Kuhora, there are some, I don't know, I cannot call them stray bullets. There were some targeted ones. If you could address them in regards to the formula, is one of them that even Dr. Lishenga had raised, as well as the exclusion of persons with HIV/AIDS.
Okay, thank you. Let me start with the last one for aggregators. The reference that we have for that, apologies for the word used, we are calling them walking billboards. Walking billboards means that patient who has had a very good experience is actually one of the best marketing tools, other than holding meetings, holding political meetings, or having billboards all over the place posted in town and all that. So that person who has a good experience, that person who can talk about how the system works, ends up drawing or attracting more or convincing more individuals to be able to take that up as opposed to other measures. It is the same thing with community influencers, it's the same thing with the providers or the practitioners, the doctors and the like. So they're not really aggregators, but more of the walking billboards who can talk about the experience and actually give a positive review of the experience. And it's one of the communication strategies that usually works very well when you are looking at change management, because one of the key things that we need to communicate is the change and the value that we are creating by the change. Now, in terms of HIV programs, TB programs, immunization programs, malaria and family planning, it's actually one of the key considerations that were done when we were looking at the benefits, because there are several things that we were considering. One is, what does the population need? And of these sponsored programs, they're actually what the population needs, and for a good number of them, not having it means a mortality. Not having appropriate HIV care, it's probably going to lead to a mortality, and therefore it is a high priority. Not having TB care means that the risk of transmission, the risk of having multi-drug resistant TBs, which are a lot more expensive. I'm not so sure whether, Lishenga, whether we've had TDR TBs, that is total drug resistant TBs, because that's almost a certain mortality, or it's going to be too expensive to manage. So yes, they were prioritized. We had estimates of about 125B, but a decision had to be made. Do we finance that? Are we able to raise the revenues? Or do we still maintain them as vertically financed programs and have a plan of transitioning over time? So the option was, we have the estimates, we have the numbers, we have the figures, let's look at transitioning over time. So it's not that they were not considered, just that the system could not absorb those costs immediately. So the intention is basically to transition. Now, in terms of the secret and well-guarded formula, I wouldn't say it is secret, now that you can be able to explain it. Just that the role of, or rather what is envisioned, one is that if you look at the law on primary healthcare, it looks at offering primary healthcare using the PCNs, or the primary care networks. Primary care networks is basically a chain or a group of facilities within the same catchment. So instead of being restricted to one provider, as it was before, you can walk into any of those providers, be able to access the care. And since they are within the same catchment, they are likely to have similar outlooks, and they are likely to have a peer review amongst themselves. So if there is one provider who seems to be pushing claims related to malaria in a place where you don't expect prevalence of malaria, then it's that community to take up that role and do a peer review of that facility and make those corrective measures. If the reason why a facility, one facility within a catchment of 30 facilities has a very high incidence of cholera, then the community health worker or the public health officials come into place and ask, where is this disease coming from? Is there a place where they are likely to be getting this transmission from? Is there a specific group within that population that is significantly exposed to that? So that kind of a peer review within that network ends up achieving more value, and there's actually quite a lot of publications around that. I think what has been the challenge is the communication, how it has been communicated, and the fact that it is a significant change. As he explained, by the time a quota was starting, a provider could actually be able to estimate that on this payment platform for outpatient, I'm expecting X amount of money. But in this case, on this model that has been adopted, it's basically not possible to predict, because it depends on the number of hospital visits and the diseases that are being handled. So a disease like pneumonia has a weighted score of 1. A disease like stroke being managed as an outpatient has a higher rating, because on average it's a lot more expensive compared to acute pneumonia. So I would say that the main challenge has been the communication of that change, and as has been raised in different forums, there might have been, we didn't take too much time to do the piloting and actually document the impact of such an intervention. Yes, we know what it's meant to achieve. We know how it is meant to achieve it, but we don't have concrete evidence, but by rolling it out, it's going to achieve that. So that is the different approach that I would use.
All right, Hyunsu.
So I'm not going to say anything, Sam. But on the question of whether we have enough money in the country for healthcare, I just wanted to, and why, donor-funded projects, programs. So what strikes me as very curious is that our healthcare budget last financial year was about 158 billion, of which 75 billion was donor-funded, which is ridiculous for a country like Kenya, that you are going to 50% of your entire health budget is dependent on the goodwill of foreigners. So that is problematic. But what I find so curious is that, for instance, Kenyatta National Hospital, Kenyatta University Teaching and Referral Hospital, Moi University Hospital, now Jaramogi Oginga Odinga, I don't know, there are about 5 national referral hospitals. If you check the published data on payments by SHA to hospitals, those hospitals I have just mentioned receive the highest payment, hundreds of millions of shillings, 400, 500 million, a billion. They receive that kind of payment. Those hospitals are the same ones that benefit from donor-funded projects. When you have a TB project, a HIV project, the money goes to those hospitals. So I have a curious question. Why, if these hospitals are receiving the vast majority of funding, do we in every single year allocate national referral hospitals 55 billion shillings? What is that? Because for me, that just means those hospitals are technically insolvent. Every other hospital in Kenya makes do with what it gets from SHA and from cash. And they pay salaries, they pay power, they pay workers, they invest in new infrastructure. But KNH, MOI, KUTTRH, and sorry if you work there and you're here, but I'm just saying the truth. Madare, those ones, why do we, in addition to the money we pay them from SHA and from donors, have to fund them 55 billion shillings? They're just 5 hospitals. Now, I want to point to you why that is so ridiculous. The amount of money we give to KU, MOI, KUTTRH, Jaramogi is enough to fund the entire primary health care service of Kenya. So, 6 hospitals only, consuming enough money to give every single Kenyan primary health care. This cannot happen. Now, there's also another level. Now, why is it that every single parastatal, every single saga has a private medical scheme? I have no problem with private medical schemes. I mean, by all means, the word is private. I have my own private medical scheme. And if you want to buy yours privately, buy yours privately. But we should not use taxpayers' money to buy private medical insurance. And that also happens to county governments. Why is it that every single county government, job group A to J, have private medical insurance on taxpayers' money? Why isn't SHA enough for them? So what I'm trying to say is that if you take parastatals, you take sagas, you take counties, you take teaching and referral hospitals. Okay, I haven't mentioned, you take Teacher Service Commission, you take police, you take civil servants, and my friend Davji will be here very soon. You take all these guys, all the money that they are sending to private hands, if it was rediverted to SHA, we do not have a healthcare funding problem in Kenya. The reason is everybody is doing business on public money, and we need this money redirected where it belongs so that the Kenyan people can get the care they deserve.
All right. Just before we come to you, Dr. Ari, you're talking about employees of government, and you don't think they should be given private insurance?
No, certainly. I think they should buy it privately. You know, if you as an employee of a university, okay, I work for a university myself. If you are an employee of a university and you don't like the SHA medical scheme, buy Jubilee, APA, UAP, GA, but buy it privately. It is not fair for us to tax Kenyans to buy you private insurance. It doesn't make any sense. Because one, you're already being deducted in your salary, and then we use your taxes on 30% of your income to buy you again. This is ridiculous. The point I'm trying to say is that if you are using taxpayers' money, redivert taxpayers' money to finance healthcare for taxpayers.
Okay. Okay, thank you. I want to, before I come to Dr. Kinyanjui, I just want to go to Bwana Chepkok and just bring it back to the conversation around donor, not being, how do we finance healthcare without over-reliance on donors? Because I know because I know KTTA, you get funding from the National Treasury, but in addition, you get from the World Bank, USAID, Global Fund, as well as some partnerships with private sector, in terms of collaborations of blood drives and the likes. So, for instance, now that we have the USAID situation, what has that done to KTTS?
Thank you for that, and I liked what Dr. Kinyanjui said. How do we man our own healthcare and do the financing? And that's why this Social Health Authority had to come in place. As I said, I think before, when we started Kenya Blood Transfusion after the bomb blast in 1998, it was purely funded by USAID and JICA. The government funding there was just minimal. It was less than 4 million. By the year 2013, when USAID started moving out, the government started putting some money. But you remember that in 2019, when USAID completely withdrew, with us, we caught the feeling just before this one which has come. We had a crisis, and I think you still remember our cabinet secretary by that time when we declared we had a crisis. This time, the government started funding the money from it was lower than 100 million to around 1.23 billion for the last financial year. Though with what really happened, the agencies, when we had budget cuts, we lost more than 1 billion shillings, and we almost went to the same place, although it has been taken care of. Why do we need to say about this? I think when we were even discussing on the packages from the SHA, we did our proposals whereby we needed from SHA, how can we get a percentage we can go to blood collection? And therefore, for you to get 1 pint of blood, we require 10,000 Kenya shillings. That's from the blood bags, the screening, the mobilization. Sometimes we come to the media and you always see us running some adverts. We need to do social mobs and even sometimes races to ensure that the public knows about blood donation. If it is part of the things we negotiated, but we can't say that we lost everything. We didn't get that one with SHA, but we got some of the few things. For our sicklers, they were able to put for the first time the so-called red cell exchange, which they are paying to a tune of 70,000 shillings. Is it not a plus for the sicklers who have been relying on donations, crisis every now and then? So right now, I think we can say we are having that. We can also talk about the transplant, because Kenya Blood Transfusion and Transplant, we always go for the transplant. Renal, our kidney transplant, the surgeries was financed by NHIF. But right now, as we sit down right now, the pre-donation, that is workup for both the donor and the recipient, is funded by the SHA. The real transplant itself is being funded by the SHA. And post-transplant, that is the drugs. NHIF used not to fund for drugs. After transplant, if you don't have money, you just can't die. But right now, we can say that SHA, the way they have come in, they have included that in the package. As the government will keep on, I think when you start something, let's improve it, let's improve it. We still remember even like the ICU charges, it was so small. But we have come to reality and say that we cannot fund this. But through that and this, the Social Health Authority, that's number one. Number two, the real health financing. I think it's high time, as we put money into our schools, can we put money into health? We need to put that money into health. If we can finance every student to a tune of, is it 10,000 or 20,000? Why don't we finance everybody in this country to a tune of even 2,000 Kenya shillings? If we can finance to a tune of 2,000 Kenya shillings, I think some of this problem will be there. We still remember the declaration from Nigeria, whereby we had to take our budget to around more than 30%. I think we have not reached there. We are still around 16 point something, yeah, or lower. It has even come lower. So the moment we put more money into health, the better the health systems. But the best thing right now is Social Health Authority. Allow me to add one thing on blood. Why are we transfusing? We transfuse because of so many issues. Road traffic accidents. Road traffic accident, when you get an accident, blood should not wait. You should not wait for the blood, but blood should wait for you. If you are going to wait for blood, the chances of you going to the other side of the wall is very high. We need to donate, and we need to put money into that, so that at any given time we have blood in our banks. We are also coming to the insurance companies. We have a lot of delays. The hospital stay. The hospital stay can always be, it's always long because of waiting of blood, either for rescheduling of surgeries, the hospital stay, but the moment if somebody requires blood and is given, things like cancer might not move from stage 1 to stage 3, but it can be, you can get blood and get your chemotherapy on time, radiotherapy on time. So that financing needs to be enhanced. Thank you.
All right, and just before we move away from you, there was a question about with USAID having the USAID situation. Where does that leave you? What has the impact been?
We suffered a long time. At this time, we didn't have any financing from USAID. We were having from World Bank, which also ended just last month. It means one thing. We need more allocation from the government, because we are not getting anything from SHA. We collect the blood, process, and we distribute. without charging even 1 shilling. That 10,000 shillings, if you take like 500,000 pints times that 10,000, we require almost like 5 billion. But we have been trying to get from other donors. It's going to leave us in a bad place. But thank you. Right now, we are not getting anything from USAID. It was only World Bank.
Okay, thank you, Dr. Kinyanjui. You had something to say before we give the opportunity to have questions from the audience.
So thank you very much. I wanted to follow on to what Dr. Lishenga said here. Why our referral or level 6 public facilities very expensive, and why we keep funding them. This is my theory. It may not be the truth. But let me start with what is published information. The bigger the hospital or any manufacturing, because a hospital is like any other manufacturing, the bigger the organization, the higher the what we call overheads. Because we have so many complexities in that facilities and a lot of idle capacity of people, idle capacity of machines that need to be paid for. There are hundreds and hundreds of pathways for a patient getting treatment because we have everything lumped up in one place. So as a result, those facilities become super, super expensive and very inefficient. The other thing, that is published information, anyone can check it up, okay? The other thing is that, is what I said. These facilities belong to the referee, who is the Ministry of Health. So he holds the money. So before he gives anybody else child food, you start serving your own, wanajaziwa mlima. Wale wengine mutakula ikipatikana. That's what happens. If you move those facilities, why is Kenyatta still under Ministry of Health? This is a question I want to ask. Kenyatta is big enough to be its own sagas, to stand on its own, get its own budget, and operate like any other facility. If it cannot afford that big budget, let it cut what is superfluous, what is not efficient. What the clients don't need, get rid of it. Keep what you need. Operate at that level. Stop competing with health centers in immunizing children and doing ANC services. That's like taking an 18-wheel and trying to distribute letters in this city. Yes, because you cause jam. That's why trailers are not allowed in the CBD. They are not allowed during the day, maybe over the weekend or at night, because they will cause jam. Let the letters be distributed now to a border and tuk-tuk. The wheeler that it is big, let it provide services that cannot be provided elsewhere. That's why it's a referral and a level 6. So it has stopped its own job, neglected what it's doing, is competing with the smaller facilities. And that's what makes it super inefficient and that expensive. Why it's getting the money all the year with all those inefficiencies, it belongs to MOH. If it was a standalone by itself, most likely it will not be getting those funds because MOH could clearly see that this is not the most efficient place to put the money. Thank you.
Yes. Allow me to say something. It will be wrong, being one of the MOH people, to leave Dr. Kinyanjui to just crucify the level 6 hospital. They are called level 6 because of the level of care. When you talk about the level of care, it's the complexities. When you talk about the complexities, it goes with the cost. Talk about open heart surgeries, which is being done there. Talk about transplant. Talk about the cancer treatment. All this has been referred from the other level. And the Ministry of Health has a policy on the referral policy. Kenyatta currently, you can no longer walk in if you don't have any referral. So we don't need to crucify and say that we have a lot of idle. Again, when you are dealing with the level of the hospital, we have the cost of the equipment, cost of the staff. Remember, at level 2, it can be manned by a nurse. Level 3, clinical officer and probably an MO. Who are the people who are manning these other facilities? We have consultants who are highly trained. The remuneration of a consultant and the nurse at level 2, they cannot be equal. Those are some of the things we base when it comes to that. At the end of the day, when we compare the costs in the private facility and level 6, they are subsidized. And that is part of the subsidization, and that's why the government put funds on that. Thank you.
So you believe that it's okay for KNH to be doing immunization and the other?
We have said immunization belongs to level 2. We no longer get that unless the only immunization we do is for the mothers who have come to deliver. We do the first immunization.
Okay.
The subsequent immunization goes to the level 2, level 3 hospitals.
All right. So I'd like to invite anyone with a question or a comment, so you can raise your hands and we will have the microphones coming to you. And we will also have a QR code that is going to be put on the screen that you can scan with your phone. Then you can give, it will direct you to somewhere you can give us feedback. So I'd request that we keep our questions brief and to the point. Just introduce yourself. If you're representing any organization, you can tell us, then you quickly ask your question and also just specify who you'd want to respond to it. Then we'll take a few of them in a bunch, then have them addressed by the panelists.
Thank you. Gwante Eric is my name. I work for Rikstar Debt Collection and Recovery. My question is more or less to all the panelists, but you can also jump in with our name. I have two questions. As regard to non-payment, as well as collection and recovery of such debts and associated activities, what innovative mitigation or adaptation measures that could be deployed in collection and recovery of debt owned by different clients, including government, alongside offering services to ensure disruption of services without compromising service delivery, revenue projection, and client intention? Second question, what role could debt and recovery services provider play in such scenarios in offloading these debt challenges? Thank you.
Thank you very much. There's the lady right behind you.
Yeah. Good afternoon. I am Emily Mkomunene. I'm a member of Network of TB Champions, a health advocate. I'm also an author for health education. I represent the communities. That is what they are calling now the community health volunteers. And I have a question or a statement that I would direct to our colleague, Dr. Kinyanjui, and acknowledge the nation media for what they have done at the same time, as I would also expect them to pick up the same. Dr. Kinyanjui, sometimes back, I think in year 2023, during the World AIDS Day, we said 42% of new HIV infections among the adolescents. Adolescents are children who are in school from the age of, I think, 13, and the universities. Now, before we've been talking about the donor funding, and now America having we donors, we are drowning on it. What are we going to do to ensure that health education is carried among this group to prevent new HIV infection, to promote drug adherence, and at the same time to ask for parents and collaboration with the Ministry of Education so that children or our young ones are taught about prevention and the importance of speaking about their health status without stigma. I would also invite the Nation Media Group to carry out that one, to take it as an awareness point among the teachers and the public so that we don't lose or have an increased number of new HIV infections and TB, drug-resistant TB among our family members. The other one goes to the gentleman in charge of SHA. As I congratulate the doctor for the private sector, thank you very much for representing the voices. I don't own a clinic. I'm just a Juakali person. Now, 2018, when we had the government of Jubilee government, when they introduced what we are calling the universal healthcare, we mistook universal healthcare to mean insurance. That's what Kenyans were made to believe. But universal healthcare, as the PS explained, it is where you are able to access quality healthcare at the point of need without suffering any financial handicaps at all. I remember I was called for an interview, and I said universal healthcare is not sustainable if we do not educate the public about disease prevention. And even if every Kenyan contributed to SHA and even to the private insurance, we don't have the capacity to withstand the demand to support and ensure that we receive the targeted cure. SHA should uptake health education for prevention. You'll go to an office and you find 75% of the staff are in the hospital seeking treatment because the insurance is paid and treatment is available for them. Will the hospitals be able to hold that? What will happen to those offices? Health education is key at the moment. Thank you.
Thank you very much. We could have one more, then we can.
Okay, thank you very much. My name is Marianne Nganga. I'm founder and president of a community group called Healthcare Peeps. My question is towards blood transfusion and donation. So we've heard that 60% of the blood comes from secondary children. My question is there any strategies that you've come up with that can be implemented so that you can be able to encourage the community to donate blood? For example, like going to established churches and partnering with them, having like a blood donation day. That way, because you know they have members and active members who come oftenly, you can have a consistent number of members donating at least yearly. That's my question. Thank you.
Okay, thank you. Let's have the gentleman, then we can take those questions.
Thank you. I'm George Mungao Okonji from the Civil Society. My question goes to the gentleman, head of private hospitals. With the debt of 33 billion shillings, what plan of action have you put in place to recover this money? Are you going to use the legal means? And will that work with this system? Thank you.
Thank you very much. Let's first of all have those questions, then we'll come for our second and final round. I think we have the question on debt recovery. We have some of them were more of comments than questions. So, Dr. Lishenga, will you be the first one to take it? So yours is how you're looking to recover your money legally or otherwise.
Maandamano. Okay. No, but seriously, I think your question ties into the question of debt collection. Number one, you asked about Eric. You asked about strategies that can be innovative strategies. So, number one, I think that hospitals must be allowed to contract federally. They must be allowed to contract federally. As it is right now, you contract as an individual hospital, not even as a chain. So even if you have, say, Hospital X, which has branch A, B, C, D, E, each branch under that Hospital X is an individual hospital on contracted separately. So when the rain starts beating on any of those branches, they fold. You get what I'm saying? So we need to move to a situation where hospitals can be allowed to contract federally like a network. This way, if it was possible, then maybe RUFA would need your services, because then we can contract you and say, on behalf of our network, can you collect? So as it is now, so we need to structure that, especially with SHA and with private insurance. Number two, I think we need legal changes to the way we contract hospitals. Now, just speaking on the SHA side, even on private sector, private insurances. I'll give you two quick examples. If you read the SHA contract, it says that, I don't know how they publish this in the regulation rather, not even the regulation, the SHA regulations, which are a sub legislation. And I even know the clause 63F, you go read it. It says that you will not charge SHA interest for failure to pay you. Now, you will wonder why anyone signs a contract. Would you sign it privately? If I sign a contract with you and told you, if I fail to pay you, no interest, would you sign it? Now, you wonder why hospitals end up signing that. It's because of the monopoly of power. We want the social health insurance to work, but remember, we are feeding, quote unquote, a monster. The bigger it becomes, the more money it has, the more powerful it becomes, the more it is able to dictate the market. It basically tells you, take it or leave it. So we need to be very careful. Yes, we want social health to work. and we want SHA to be properly funded. But legally, we must put enough checks and balances and brakes on it so that it does not become a monster that consumes all of us. So that's what I would say. So obviously, the new chair of the Parliamentary Health Committee, Nikal, has work to do in terms of reforming the legislation so that players are protected. Finally, on 33 billion. To be honest, I think that the government is very aware that the one weapon we have is withdrawal of service. President said on 5th of March that all debts less than 10 million shillings are payable immediately. And any debts above 10 million shillings will be subject to verification. Now, in this country, we have gotten to a point where the word of the president means nothing. If a head of state tells you pay immediately, it means immediately. So the question is, I don't want to say the president was not being truthful, but he gave an instruction. If you read the memo, it was, debts below 10 million shall be paid immediately. We are 7 weeks later, no debt has been paid. I think the question we are asking as a sector, is it that the ministers didn't hear him, or they dare ignore an instruction from the head of state? You know, so these are questions we are asking. But we think that there is a narrative being pushed now. SHA is working, therefore NHIF was bad, therefore forget NHIF. This is a very unfortunate narrative. The reality of the matter is that NHIF worked for a lot of things, it didn't work for some. SHA is working for some things, it is not working for others. So we should stop the idea of demonizing NHIF in order to run away from the debt. But sisi tuko macho tu.
So with this presidential directive, which from what you explained sounds like it was a suggestion.
No, it was not a suggestion.
Yeah, I mean, I'm just saying from how it has been responded to. Is there the presumption that anybody who was owed 10 million shillings and below was above board in terms of the integrity of the engagement? Because the rest are going through verification, but the 10 million below was meant to be paid automatically.
Okay, so Dan, let me just say this. The head of state does not give suggestions on his official handles. He gives instructions. So this was not a suggestion, this was a presidential directive. Presidential directives need to be honored and acted upon. But in terms of 10 million and below and 10 million and above and verification and fraud, I will tell you this for sure. This amount of money that they're talking about, 33 billion shillings, is uncontested debt. In other words, had gone through the branches, had reached payment at headquarters. So in fact, the reason why hospitals that are owed above 10 million, and a lot of them are public sector hospitals, so I'm not only speaking for private hospitals, I'm speaking for all hospitals. The reasons why they are not happy with that verification, it is double process. The claims had already been verified, they had been approved and reached accounts payable, they were ready to become money. So, as a sector, we have said, fine, if you still don't trust it, okay, verify. And we are very happy that CS Duale has gazetted a verification committee. But that should not get in the way of cash flow. My worry is, as we continue to strangle cash flow to the health sector, it is not, you cannot be saying you're punishing hospitals. Hospitals will transfer the cost of healthcare to common Kenyans. And that is now going to be the real tragedy of the transition.
Okay. Thank you for that, Daktari. He's talked about the debt aspect. I think some of the other specific ones. Emily had asked about networking, rather partnerships, not about what to do to have more awareness on HIV infections. And so Dr. Kinyanjui could briefly take that as we start drawing to a close.
Emily, thank you very much for always representing the communities and standing tall. What you mentioned are very critical and worrying situations, that our young people who are our future, our current and our future, because by the time they are aged 12 to 24, and in particular this age group, particularly the most affected are the girls. The boys usually catch up after 24 in terms of HIV transmission. It's a very worrisome situation because we were thinking about and dreaming about 2030 AIDS-free generation. And there are many barriers, like you've mentioned, one of them being awareness. Lots of the people on this stage grew up when HIV was a scare. and the situation has changed, and the right information is difficult. And I really like the challenge you're giving the nation about finding out how much, to what extent our teachers are aware about the HIV problem, what can be done, and the correct information. And if they have the courage and the opportunity to pass these life lessons to our growing young people. Because my interaction with the Ministry of Health and its and in the Ministry of Health is that they're very, very, very conservative. Take, for example, my visit to a teachers' college. I won't mention it here. That in a teachers' college, it is contraband to have a condom. We were stopped from putting condom dispensers or talking to teacher trainees about condom and sexual education. If they are barring teachers who are going to teach our children about this information, you can imagine what information our young people are getting. So I think this is an issue we cannot expand on here, but I just wanted to put that one out, that you cannot go and put a condom dispenser in a TTC. TTC, the people there are how old? They are above 18. Yes. For all I know, they are above 18. And therefore, there is a real restriction. For prevention purposes, for TB and so on, TB and HIV are very much related. If we cannot stop the tide of HIV, then we are going to do nothing about TB, because 40% of us here, and maybe, yes, maybe Dan is accepted from the four of us here, the DRs here. I can almost guarantee you that they are 100% infected with TB. They don't have TB disease, but they have TB germs because of where we have worked, where we schooled in college and where we have worked. We have interacted with TB. It's sitting somewhere in our body. So if the immunity goes down, TB will flare up. So we must be able to stop HIV completely. We have all the technology that is needed, the treatment, and the people and the knowledge, if we are going to be able to contain and end TB in this country. Asante.
All right, thank you. There was a question by Marianne Nganga talking about partnerships for blood drives.
Yeah, thank you for that. And I think as KBTTS, we have, the first thing we have done is doing partnership. It's not even far. The other, I think last month we were in Nation Media Group doing partnership on collection of blood. We are really extending. We always have even days like border. We have days in a year, around two days in a year, whereby we have border weeks. We have also, every county right now, we are working with the youth, and we have the youth technical working groups on blood. We are also working to students' leadership in all the universities. The other day, I was in Garissa meeting the religious groups, trying to sensitize them on blood donation. And in recent, that is the way we go. Currently we do partner with churches and everybody. And Mary Ann and everybody here, if you have an organized group, kindly tell us. We'll always come to where we are. We are ready to come to where the blood is, not to tell you, go all the way to our blood transfusion. The other thing we have done is expanding. Every county right now has a blood satellite. These blood satellites, they're able to go out to do sensitization and collect blood from the market. The other challenge which we want to introduce is the issues of using buses. And soon we are trying to work with other partners, and we will be seeing us in buses. You don't need to come from Westlands all the way to KNH where we are to donate blood. You'll be seeing us stopping with our bus. The bus is well equipped with the donation facilities, and you'll donate where you'll be. Thank you.
All right.
Thank you. I'll respond to Marianne. I'll also talk about domestic resource mobilization, what we call DRM. It's one of the key issues that have come up, especially because of the global geopolitics. What happens if the donors withdraw? What happens if there's a significant reduction in the resources that are coming in from outside? Now, as we look at having more money being allocated for health, from a financing perspective, we also must look at how do we get more health for every shilling that is being spent out. And that's the reason why we cannot talk about domestic resource mobilization without value-based financing, because we need to get maximum value out of what we are spending. And one of the ways to do that is to actually appreciate and acknowledge that we, as a system or as a country, we will not be able to raise each and every shilling that is needed to finance healthcare. And therefore, we need to have priorities. Where are the priorities? Within the ministry or within the healthcare space, and also between healthcare and the other spaces. Because if we still keep spending so much on other sectors or other areas and neglect healthcare, then we are not going to achieve what we need. And I don't want to talk about the impact of investing in preventive and promotive health, because there is actually a local study which has been done. By investing in prevention, by investing in those promotive messages, the return on investment compared to treating the case is more than 900%. So there is a significant value in financing preventive and promotive health. Then when we look at the treatment itself, there is significant value in financing the treatment plan comprehensively compared to taking up part of the costs. And I will use 2 examples to highlight that. As it was, one of the challenges that NHIF was facing was the average cost of financing treatment for cancer. So in as much as we were spending more than 2 billion shillings a year for the population that had been covered, there was still a significant out-of-pocket payment, and we're looking at figures of 63%. So yes, the fund was taking up quite a good amount of the costs, but there was still a significant amount that was being paid out of pocket. And when you look back on the reasons why, of the cancers which were staged, 81% of the cancers were presenting in stage 3 and 4. So on average, the cost of treatment ended up being too high. So investing in early diagnosis, investing in screening within the population, investing in early optimized treatment has a lot more value than waiting for a patient to present when the disease has spread a lot or is a lot more expensive to manage. Then we are not just looking at healthcare as something that exists by itself. Healthcare exists in an ecosystem. And in the communications that we've had with Treasury, we are looking at the impact of financing healthcare as a subset of the whole ecosystem. And we used a return on investment modeling for cardiovascular diseases. Based on the data that we had, about 83% of the chronic diseases were actually cardiovascular. That means the strokes, the anginas, the congestive, congestive diseases, the hypertension itself. So there's quite a lot, there are quite a lot of individuals who are having to be managed for hypertensive diseases. So what is the return on investment modeling? Now, on average, NHIF was just taking about 49% of the costs of the treatment for cardiovascular conditions. But when it comes to what is the impact if we were to finance everything, compared to what would be the value that this person would have to the rest of the economy, if they remained, if you reduce the number of hospital visits because you are managing them better, if you reduce the hospital stay, so if they are admitted, instead of a stroke case being admitted for 10 days, you have that because there is adequate treatment that is being offered, and there is less in terms of out-of-pocket payment. And on average, you also reduce the number of deaths that are related to this condition. How much would this person contribute to the economy? And when we did a 10-year analysis, our return on investment was 380%. So basically, for every 100 shillings that you are putting into management of cardiovascular conditions, that person is contributing 380 shillings into the community. Therefore, putting monies into the healthcare system ought not to be seen as an expense. It needs to be seen as an investment, because that's how we are going to get value for the money that we're spending.
All right, thank you very much. And I will have the mic come for our last round of questions. We may not be able to accommodate all. I apologize, because we need to close this. We'll just take them briefly, have our panelists respond to what they are able to, then we do closing remarks, and then we can go for lunch. So let's kindly keep our comments and questions brief, just so we can accommodate.
Thank you. I'll try and squeeze them as much as I can, because there's a lot. My name is James Kamau from Kenya Treatment Access Movement. I'm also a health economist and a HIV and AIDS activist. I'll start from the last speaker. When you talk about returns on investment, it is not just about how much you have saved. That's a very theoretical, I'm an economist, so it's a very theoretical issue, and it works on paper. And that working on paper is what has brought problems to SHA. So I think we need to look at it. We also need to look at what is the return on investment from saving that patient to be able to contribute to the economy. How much have they done? So as much as you do that, it is important. And there is a sustainable transition roadmap that we did as a country, which covered HIV, TB, malaria, non-communicable diseases, maternal-child health, and blood transfusion. And that is what the minister the other day was using when saying this is what we are going to push into the budget. So yes, we have gone very far on those particular issues. Blood transfusion. Yes, medicine is, blood is an essential medicine. But I think what you need to tell the rest of the audience is that 1 pint of blood can save 4 lives. Red blood cell, white blood cells, plasma, what's the other one? Yes, okay. I mean, this is something that requires to be put into place so that as we are going ahead. And if you don't do that, you're not going to convince the guys in parliament to put more budget into that. 34. Hello, sir.
Thank you very much.
It is not 33, it is 34 billion. Eh? The amount that is owed. I've been very accurate. Eh? Now, we have SHA, social health insurance. Can you tell us, because you are in that, we were told there are very many people who have registered. How many registered and fell along the roadside? Hello? Are you getting what I'm saying? In NHIF, we had very many people who would register. Sorry, I'm not being against certain gender, but you want to go to hospital for a certain issue, and you are told to pay for your 3 months, and you pay for it. And after you finish, you've gone. But on record, we have that particular person paying.
Okay.
Budget now, the last one, you know, the problem is, I came a bit late. And the minister, in fact, there's a question I wanted to ask the minister, she didn't, I mean the PS, who gave us a rosy picture of that the government is paying for public health and critical condition. Not a single shilling has been put in that. And I can tell you that in front. Now, we lost a lot of money from the Global Fund, I mean from the USAID and everything else. They are doing quite a bit in here. But we have some good examples of trying to mitigate. Coptic Hospital, for example, which runs one of the largest comprehensive care centers for HIV, TB, and malaria, because they started receiving back the drugs, they, as a board, got together to pay the workers, the healthcare workers who are in that area, so that it could continue. And the same thing happened in Bagathi Hospital. So I think, in as much as we are there, we do have opportunities within which to change and to be able to move forward. Thank you.
Thank you very much, Bwana Kamau. Let's take 2 more kindly, then we can, and I apologize for those who may not get a chance to ask. During lunch, if you're able to speak to any of the panelists who are around or their teams, you're most welcome to do so.
Thank you very much. My name is Frederick Odhiambo. I work with the Economic and Social Rights Center, commonly known as Haki Jamii. I have 2 questions. One for SHA. And I think you really elaborated very well that the issue of registration. Registered 13 million, but only 10% contributed. So I work with very marginal communities, maybe Narok, Samburu, and all that. The main problem that is there was public participation. And the issue of proxy means testing did not come up when we were enrolling SHA. So when I go and register, and then I realize that it is not, I'm not going to pay 500, I'm going to pay 1,500, why should I pay? Why can I go for private insurance? So what are you doing to address that issue of public participation, because that every individual is aware of the reality and the protocol that is in SHA, especially on the issue of proxy mean testing. The second question is to Dr. I can't get the name, but the guy from RUFA.
Lishenga.
Lishenga. I come from a human rights organization. And there has been a lot of human rights violation in private hospitals, not only for patients, but even for healthcare providers. What are you doing? Are you having some legal framework? Because you find that most private hospitals, actually the best business to do in this country now is opening a private clinic. And then you can charge whatever amount you want to charge, especially when they realize that you have private insurance. They just ridiculous prices. I normally have a problem with when I go to the hospital, because you find this, they dispense the same antibiotic with different prices. What is the difference? Because it's the same antibiotic with the same component. So what are you doing to ensure that we don't violate the right of citizens, especially on the part of affordability in the private hospital, because you have assumed the business model and it's business as usual, and we're not caring about humanity. Thank you.
Thank you very much. All right, let's have the final one.
Thank you so much. I'm Jacob Ngumi. I work with an NGO, Young Professionals for Development, a member of Health NGOs Network of Kenya, NNET. One issue is to SHA. Do you have an awareness department to handle issues of public participation, issues of doing awareness, even to the pastoralists and the robos right in the village, to know that they need to pay for SHA? Do you have an adequate budget for that department? Number 2, to all the panelists maybe, or even to SHA and to Dr. Lishenga from RUPA, one of the issues is that from the Almata Declaration 1978 and the Abuja Declaration, there was a shift towards preventive, not curative. That means you reduce the disease burden in hospitals by 80%. If you do that, you reduce the budget of health in Kenya by 80% if you focus on preventive and promotive. In this country, we have never seen that shift, despite Kenya signing those legal international instruments, which were they agreed upon as a government. You are still focusing on curative. What mechanisms are put in place to be able to achieve that? And I can assure you, doctors and nurses, you won't lose jobs. You will still go to preventive and promotive, not clinical care. Number 3, to the Nation Media Group. Are you able to bring community voices to these national platforms? You bring the Dorobo, the pastoralist, someone from Turkana, and the Dorobo living in Mau Forest, to tell us what is their view that they have, like the pastoralists has like 20 cattle, or 100, or even 400 they have, but they cannot pay for SHA. They are wealthy than me, but they're not able to afford. So what are the reasons? So that we get the national inclusivity in terms of these debates, which we're having at the national level. Thank you.
Thank you very much, Jacob. So that's quite a lot of questions, but some are similar. Some of them share similar pointers, and some were comments, more of just comments and insights from various persons, such as Bona James Kamau, who says that your debt is 34, not 33 billion. Kamau jui pesa unahitaji. So maybe we could begin with Dr. Lishenga, anyway, there are some questions that have come to you, like human rights violations being one of the key ones, and how to try and mitigate the debt situation.
Well, thank you. Maybe I will take the human rights question first. So one of the things that happens, and I don't know why you chose patients with private insurance, maybe not a very good example. Patients with private insurance, generally, the cost of care is imposed by the insurance in contract. So you cannot charge beyond certain limits. But we'll comment about cash-paying clients and the cost of care. Now, number one is that we do need to have more awareness, because we live in a liberal market. So one of the things that you will realize is that the cost of care varies from hospital to hospital. Why does the cost of care tend to be higher at private hospitals than, say, public hospitals? The answer is very straightforward. The cost of care in private hospitals is much closer to the actual cost of care than actually what you see in private. So let me give you an example. If you pay, so public hospitals have their salaries paid for their workers, electricity, they don't invest in land. They generally get off on paying for licenses and regulation. All these things add up to the cost of care. I'll give you an example. And this is something that it's an important national conversation. So if you wanted to open and I want to correct you on opening a clinic is the most lucrative business, don't try right now. Well, then you have to go to medical school first, etc. But, that is also a cost. But if you were to open a healthcare facility today in Kenya, you need to acquire 17 different licenses. 17 different licenses, just to open, and each one of them has a cost. So KML, TTB, Kenya Radiation Board, Kenya Medical Practitioners and Dentists Council, PPB, Music Copyright Society, City Council license, and the list continues. Each one of them has a cost. So now, not only do you have to pay these costs, you have to maintain them on an annual basis, including things like indemnity, professional indemnity for the doctors, hospital, medical, insurance, So it is quite expensive to actually start off and maintain a healthcare business. The other thing is that you need to look at what we call the Baumol effect, the fact that there is a limit to productivity that you can increase for healthcare workers while also reducing costs. So some people argue that it gets people to do more so that you drive costs down. But if a consultation with a doctor takes 15 minutes, there is no way you can, if you hire a better doctor, it doesn't become 12 minutes. And therefore, you don't reduce your costs that way. So it's a service industry. It's one of those industries where we are faced with ever-increasing costs, So nurses have to be paid more. If you get more advanced nurses, you have to pay them more. So the question really is not on, is it too expensive? The question should be, what is the actual cost of providing care? And then, can we pay for that actual cost? I would prefer a country where you don't have to go back into your pocket to pay for services. And this is part of the reason why we keep agitating and keep saying that we must properly finance healthcare services. Right now, we are collecting 6 billion. I don't know, Kuhora will correct me, maybe 6.5 billion at best under SHA. Only 1% of Kenyans have private healthcare insurance. It might be less than that. Now, if we are doing 6 billion shillings, that's mostly coming from formal sector employees. We wanted to, so in a year it will be maybe maximum 75 billion. Now, how much do we need? Our smallest estimates were saying something like 275 billion, okay? How do we bridge the 200 billion deficit so that when you attend hospital, you don't undergo catastrophic expenditure? I do need to say this, however, that we do have healthcare providers, both public and private and faith-based, where violations of human rights do happen. That does happen. What we need to do is do more public education. Now, for instance, let me give you an example why some of these things don't go very well. They are not being attended to well. When somebody, your relative or somebody close to you passes away, in a situation where you think there was negligence, what are Kenyans doing today? They go to DCI and report. Now, you start off on the wrong footing. The first place you should go to is KMPDC and launch a report there. If you go to DCI and a pathologist writes a report to DCI, how many DCI officers can read a pathology report? They cannot read it. So even if you are suspect that it is negligence, your case is dead in the water. So we do need to have public education that if you have a medical case where you think there was negligence, where do you start? Where do you complain? Now, that is something that we need to talk to the people about. Okay. On the issue of Alma-Ata and preventive healthcare, I'll just give you a short answer. We have not incentivized it very much. Under the social health reforms, for instance, now we have cervical cancer screening, prostate cancer screening. These are now benefits which are payable. But if you read the Gazette notice by the Minister of Health in February, it said that subject to availability of resources. What does that mean? It means we know that preventive care is important, but we are not putting the money there. I'll give you an example. Another example. Why don't we have a package in SHA, for instance, that pays each hospital that gets a patient off cigarette smoking some money? So we know cigarette smoking is responsible for cardiovascular disease, cancer, and all these things. And we have that as a major problem. But why would I, as a healthcare provider, help you quit smoking if nobody is going to help to pay for it? So we do need to incentivize preventive services. Diabetes patients who stick on a diet and lose weight, we should be paying hospitals that help diabetic patients that stick on a diet and lose weight and control their sugar a bonus every year for doing that. What will that do? It now goes to what my colleague was saying, value-based care. It is not enough to pay a hospital for giving medicine. You need to start paying providers for helping lifestyle choices, for helping hypertensive patients become better controlled. Okay. So these are issues that we have not thought about critically as a nation that we need to do.
All right, thank you very much. I want to go to Dr. Kuhora. Briefly, there are some questions on SHA, public participation, which is tied to also awareness. And we have, I think there's a question about how many registered in SHA and fell off.
Okay, thank you. On the two, that is the question by Odhiambo in terms of public participation and also the awareness department. Yes, there is an awareness department, and I will not use the same words that my colleague used, that it was done as a coercion, but in my view, I think the communication was not effective because we have to factor in several things when you are looking at change communication. That communication needs to be transformative. Somebody needs to be seeing the value of one over another. And that's one of the things that my colleague from the transfusion services has mentioned. There is value that has been added, but has that value been adequately communicated? That is one challenge. I'm not a communication expert. Probably my colleagues around here might be able to comment on that. And then the second thing that needs to be achieved is that there has to be some sort of a unified message. If you look at the different sets of communication over the last, let me say, 1 or 2 years, it's been varying over time, and I think that's one of the challenges that we've had with RUFA in terms of what is the exact position. So that aspect of having a unified message that everybody speaks to the same thing is probably one of the challenges that have made the acceptance of the PMT and also the effectiveness of the communication to be a bit low. So not really that the communication is not there, probably it is not as effective as it should have been. Then there's the issue about the falling off and the likely impact. So as I mentioned, the active registrations are about 17 million. Actually, if you look at it wholesomely, because you remember sometime in September, everybody who was within the NHIF database was prompted to accept to move into the SHA database. So if you look at everything cumulatively, we are looking at a figure of about 22 million. But then the ones who activated their accounts within SHA wholesomely is about 17 million. then of that 17 million, how many of them are in the formal sector? Because the dynamics are very different compared to when you compare the formal sector and the informal sector. So within the formal sector, we are looking at a figure of 3.4. And of that 3.4, 3 million are actively contributing now. So there is a population of about 400,000 that either the employer had not made the remittance on time, or they might have fell off at some point. That is within the formal sector. So a retention of about 88, 89%, which is pretty good compared in the dynamics that we are looking at. Now the challenge, as I mentioned, is with the informal sector. Of that population that went into proximity testing, 1.3 made at least one contribution. That is at least one contribution in the last 6 months. But if you are to do a cross-sectional analysis now, how many of them have retained active contributions ever since their first contribution? The figure drops lower to about 440,000. So there is a challenge with the informal sector. We need to collectively look at it because it is one of the challenges that we had anticipated we are likely to face. And we need to support this population, not just to know about the product, but also trust that when you put your monies and you need it, the risk is going to be covered. And then have friendly ways of having this population to be able to pay. Thank you.
Thank you very much, gentlemen. And I will just give each of you 1 minute to just give a closing remark. Contain yourself within 1 minute. You're the ones holding these people from lunch, and that is not the most enviable position to be in. So I'll begin with you, coming this way.
Okay. I think mine is just to tell the members that donation, and when I'm talking about the donation, I've talked about blood, but we still have other donations, cells, tissues, and organs. The economists have said, how can we add value to life? When you do a transplant, this person is going to be more productive. Can we start a discussion on how we can donate more than blood, tissues, and organs? And if you have never donated, today we have come next to you. There in the booths, you can do a blood donation immediately. You'll be big-hearted, you'll have saved more than, we always, when you donate one, you can save up to 3 to 4 people. And without saying the components from Kamau. Thank you so much. Be regular blood donors.
Thank you very much, Bwana Kiprono.
Okay, thank you. Now that I'm holding you for lunch, I would just want to pass the message that a chain is as strong as its weakest link. If healthcare remains our weakest link, then it's going to affect all of us. We need to appreciate that at the end of the day, healthcare is also your responsibility. In as much as we would want to finance preventive health, you also have a role when it comes to preventive health. In as much as health financing is one of the key tenets of healthcare, healthcare exists in an ecosystem. I'll give an example. Kigali has, is it a 2-kilometer tartan track just for walking? Is it possible to have such a thing in Nairobi? It has its role. Urban planning has its role. Financing has its role. Water and sanitation has its role. So it's a whole ecosystem. It's our responsibility. Thank you.
Thank you very much.
So thank you very much. I'll go back to the 5 things that I mentioned, but I'm going to just be very brief on them now. I'll give a relevant example that I'd like the audience and all of us who are listening to remember that, as Dr. Kora has already said, that health is our responsibility. But we have duty bearers, and that is in the leadership position. We need what are called choice architects, choices that are designed in a way that are able to guide people to make the change. We cannot wish that change happens. It has to be choreographed. And as Dr. Rishenga has said, there must be resources to guide people in a certain way. If whatever we fund is what the providers will provide. Having said that, is that I go back to say that we need to change the business model in healthcare. It doesn't matter how much money we collect, Dr. Lishanga. Even if we collect the 300 billion, and we are predominantly just going to fund fee for service, it's unlikely that our health indicators will improve. If there is a living example that we have, is the US. The amount of money they spend, and if you look at their health indicators, compared with other developed countries like in Europe and so on, you will see clearly it's not the money only. It has to be the money, it has to be the purchasing design, and it has to be, there must be ways to measure who is doing a good job from those who is not doing a good job. And therefore, direct traffic and funding to those who are doing a good job. Those who are who are violating human rights, we should be able to find a mechanism to find them and set them aside. If we don't change how we've been doing business, if we don't focus on the things that matter, outcome, clinical outcome, value for the respect and care for the patients, and paying the providers in a timely manner, then the cost will continue going up because they must factor in the interest. Whether it is written as interest or no interest, it will still come.
Thank you.
Thank you.
Thank you very much. Dr. Lishanga?
So very briefly, there is a nice show I like that comes on NTV, used to come, I don't know if it still comes, called Courage the Cowardly Dog. Now,
your age is showing.
Now, government of Kenya is like Courage the Cowardly Dog. It has a very nice name, Courage, but it behaves cowardly. One, there needs to be courage here in making sure there is enough money for healthcare, as I mentioned. The money that we are spending on the referral hospitals, the money that we are spending in the counties on parastatals, etc., that is more than enough money to help Kuhora do his thing. But it will require courageous leadership to get that done. That is number one. Number two, I think that we will never get the informal sector to collect the kind of money that will make SHA happy. The reason is it is voluntary, and all of us, if we are not sick, we have no reason to contribute. So here is my suggestion, and suggestion that we have made to the government. One, the road maintenance levy. The road maintenance levy, which was before 2024, 18 shillings per litre of fuel, was generating 80 billion Kenya shillings. Just that. On fuel alone, on one product, was generating 80 billion shillings. In the last finance bill, it was increased to 25 shillings per litre. That is going to generate 115 billion shillings. That to help maintain roads. Our suggestion has been that for healthcare to be properly funded, we need to move away from proxy means testing and telling Kenyans by knowing whether your house has tiles or whether you have a motorcycle, you will contribute X amount of money. It is extremely unpopular and it is unlikely to work. What we have suggested, and the suggestion I want to make today, is we need to finance healthcare through an earmark tax, similar the way we do to the road maintenance levy. We can decide which products can be for earmark tax. If you decide it is shoes, and Lishanga buys a 7,000 shoes, he contributes. And someone else can only afford something for 300 shilling, they also contribute. This is how we will finance healthcare. So we do away with proxy means testing. It is very invasive. There was another idea about we will track your M-Pesa transactions and remove money from there. Kenyans don't like this kind of things. So we go back to a rational financing mechanism that is painless, and then we can get enough money into healthcare and deal with the problems we have. Thank you very much.
Thank you very much to the general. Let's appreciate them. We've had, at the very far end, we've had Bwana Kiprono Chepkok, the head of partnerships at the Kenya Blood Transfusion and Transplant Services, KBTTS. We've had Dr. Samson Kuhora, the head of planning and linkages at the Social Health Authority. We have had Dr. Samuel Kinyanjui, the country director of AIDS Healthcare Foundation. And we've had Dr. Brian Lishanga, the national chairman of the Rural and Urban Private Hospital Association, ZUPA. Thank you for your insight, gentlemen, and thank you all for being part of this discussion. There has been a lot of insight. There may be a lot of questions, so we'll request that if you get an opportunity to see some of not only them, but also their team members around here, feel free to reach out and speak to them and ask for or share your ideas, and we shall see how you could get assisted. Thank you very much. We now take our lunch break. We should be back seated here at 2:40 p.m. 2:40, 2:40? 2:15. It's now 1:54. Yeah, 2:40 it is. Thank you very much. Our panelists, once again, thank you. You may step down, and Naomi will actually guide you. Thank you very much, ladies and gentlemen.
That young Kenyans and Kenyans in general are putting in place to solve the problems that Kenya faces in the healthcare sector. So the whole aspect, the whole space of digital health, that is what we'll be addressing this afternoon. And so we've got an exciting list of innovators who'll be telling us about the kind of innovations they're putting in place and how these innovations have transformed the lives of Kenyans, the Kenyans that they've worked with and the Kenyans that they continue to work with, and which of these innovations can be scaled up to be replicated across the whole of the country. And so without further ado, I'd like to invite Dr. Robert Nyarango, who's the Chief Executive Officer of Gertrude's Children's Hospital, who will tell us about what Gertrude's is doing to transform the lives of the patients. Dr. Nyarango.
So good afternoon. I'm here to talk about Dr. Smart. We thank you for Nation Media Group for inviting us to share experience with deployment of telemedicine to address some challenges that we think if not sorted out, then will not advance universal health coverage. So Dr. Smart is a collaboration between M-Pesa Foundation and Safaricom, for that matter, and Gertrude Children's Hospital. The program currently is funded largely by M-Pesa Foundation and the Gertrude's Hospital Foundation, but the actual implementation is done by the Gertrude's Hospital. So I'll be talking more of the implementation part than the financing part. Okay, so those who may not have heard about Gertrude's, we are very happy that as we discuss about making Kenya a hub for medical tourism, we are playing a small bit in that. And as you can see, is that Gertrude's is becoming a regional hospital. Our approach is not to take the hospital to the countries around, but rather to have the patients come to us. So of the many patients that we attend to every year, about 400,000, about 10% would come from the neighboring countries and as far as Western Africa. But let me talk about, okay, if you can move to the next, okay. Okay, so why are we doing telemedicine? Telemedicine would be applied a lot in primary healthcare. I mean, quick solution, somebody has a cough, you call and you're sorted out. It also has found application in chronic illness management. You have diabetes and you're in control and you have somebody who checks in once in a while to sort you out. But for us, the approach was to try and cure a problem, probably if I may call it that way, that is very challenging to sort out, and that is the availability of pediatricians. Kenya is roughly now 57 million people. Of those, half are below 19, and typically those are what we call children as far as healthcare access is concerned. Those will be attended by a pediatrician. So that is really half of the population. So our starting point was to find out how many pediatricians do we have available to take care of those. And the country right now, Dr. Kariuki is here, he may correct me, we have about roughly 650 active pediatricians. And that is why Kenya has less than 5 pediatricians for every 500,000. WHO required 1 doctor to 1,000 population and 1 pediatrician to 5,000 because it's specialist care. So if you take the 28,500,000 people below 19, divide by 650, you'll notice that you're very far from that. Of the 650, the majority will be in urban areas, Nairobi, Mombasa, and so many other places. So the large parts of the country will not be served. So even as we try to train more pediatricians, there are still many patients to be served, and that's really what you're trying to address. And so we looked at the map. There's a Kenyan map for this, which shows distribution of pediatricians, and we realized that about half of the counties, of the 47 counties, do not have a single active pediatrician. So there might be a pediatrician who is part of the admin and so on, but actually seeing patients, they do not have a single pediatrician. So that was a starting point. Okay, I'm going backwards. So, and also obviously we needed to plug into the national agenda about equity, about access, about deployment of technology, and so on and so on. And so the quickest solution we thought then would be application of technology. And so I'm going to explain briefly how our solution works. So you have on the upper left, a remote site outside Nairobi. This would be about 400, 500 kilometers from Nairobi. And so what you're seeing there, the pointer doesn't work too well. All those gadgets you see there are actually medical devices. So you have a stethoscope, you have a Dama camera, you have an otoscope, you have an ECG, you have an ultrasound probe. And so these gadgets will be at the point where the patient is. They'll be linked via fiber optic or whatever it is channel to what you have on this side. This is a pediatrician sitting at Gatu's hospital. So all the input from that side, from the patient perspective, will show up at the desk where this pediatrician is sitting. Of course, there's a headphone there which you may not be able to see. And so the doctor here can listen to the heart, can listen to the chest sounds, can literally examine the patient. But they must have a clinical officer or somebody at that end to work with. So it's a referral process. So patients come, the clinical officer determines that this requires to be attended by a pediatrician. They book them. We have built a room there with all these gadgets, and we worked with Safaricom to put up a connectivity. And of course, they'll be booked, and the doctor on this side will attend to the patients. So that is one. So that is attending to the patients. And of course, because there is audio and visual, the pediatrician on this side should be able to ask questions, or ordinarily ask questions and take a history and so on and so on and so on. And then prescribe treatment, whether it's a course of tests or whatever medication that is required, or determine that the patient actually requires another level of care. What you have on this down here is those are healthcare providers in that remote area who may require some education. So out of the many patients they've seen, they can decide that there's a challenge in diagnosing this. The issue of continuous medical education that we have in healthcare system. So these are sessions. So the same platform will be used to provide continuous medical education. In some counties, the patients are in a very remote area. So we have to take a mobile clinic, which has all these gadgets and the setup and 4G or 3G, which then again connects to the hub in Muthaiga. So through that process, then we're able to attend to the patients. And sometimes the patients live really far away. Sometimes you have to give them fare to come to the site where they're supposed to be seen. So in a nutshell, that is how this Dr. Rispat process works. Okay. So so far, this has been running for 3 years now. Of course, one of the challenges, the setup took a while. It took almost 1 year to set it up because you had to go and negotiate with the county governments. Most of these are set up in public facilities, get a space, build up the room, put connectivity, train staff, work with community health volunteers, to sensitize and so on and so on. And so we're in 5 counties, Samburu, Baringo, Lamu, Homa Bay, and Narok. Of course, those are criteria for choosing those counties. The first criteria was availability or non-availability of a pediatrician. Of course, there are health outcome indices that you look at, mortality rates, neonatal mortality, and so on and so on and so on. And of course, geographical distance. If somebody there was told to refer to a pediatrician, what are the likelihood that within a short period of time they're going to see a pediatrician? So in those 5 counties, we have 6 sites, 5 in public facilities and 1 in a faith-based facility, that is in Baringo. So in those 3 years, we've attended to 23,702 patients. And then of those, 1885 have been referred by the pediatrician to subspecialist care throughout many different specialties. Through the mobile clinic you saw there, we've seen about 5,000 patients. Of the 1,800 that have been referred, some of them we had to bring them to Nairobi for care. So the last, so this patient here is an example of that. This is a child who was picked in Samburu, had a heart lesion, transferred to Nairobi, had open heart surgery in Muthaiga, got roots and sent back to Samburu and living. And we've done, I think, like 8, 9 of those open heart surgeries. From this process, we have 12 patients identified with leukemia, put on treatment. 7 of them have completed treatment, 5 are undergoing treatment, and luckily, there were 13 of them. Luckily, unluckily, one of them died. So the last point I want to make is, what are the lessons that we've learned from this? Number one is that the process actually works, because for us it was probably more of a proof of concept that you get as good care as if you're in the same room with a pediatrician. So the process works, number one. Of course, there are many other lessons that we can learn. Number 2 is that there is need for sustainable financing. Remember, this is a funded product. So once we prove the concept, then we are going to go to SHA and everybody else and say, look, instead of somebody in Baringo not getting a pediatrician or staying for 3 months, or we can provide access the care, they can access the care, but then there should be a reimbursement process, whether it's SHA or private insurance or cash. There are very many lessons. This is a very good case for private-public partnership, and there are very many good lessons which I may not go into. Once we publish the reports, we should be able to pick the lessons. What are the challenges? What are the things that work? And how can, my sense is that this private-public partnership probably accelerates the process more than each sector trying to do their own things. Having said all that, we were not trying to say that we should not train pediatricians. So we should still train pediatricians. Remember the original question you're trying to sort out. So even as we deploy technology to do all these things, I think it's critical that through the Medical Council, the universities and everybody involved, there's now a new collegiate model for training pediatricians, which we've started in partnership with the East Central and Africa and Southern Africa Collegiate of Pediatrics. So we still need to train pediatricians. But even as we do that, we think that there's scope to deploy technologies such as Dr. Smart to provide specialist care. Thank you.
Sorry. Thank you very much, Dr. Nyarango. I hope there are some lessons that other healthcare facilities could take from your presentations, and maybe even opportunities to work together. Remember, in the morning session, we said we are not here to tell stories of despair. You read enough about that. You live, some of you live enough of those stories of despair. So we're here seeking solutions. And if some of these solutions can be found in partnerships, why not? Maybe some of you here can find new avenues or new ways to do business by working together to deliver the quality healthcare that Kenya needs. Now we've heard about telemedicine. So now we talk about AI in TB diagnostics. How is artificial intelligence being used to diagnose patients with tuberculosis? And this is a presentation we'll hear from AI MedVision, and we'll hear from Louis Lennox.
Good afternoon, ladies and gentlemen. My name is Lewis Lennox. I'm a fourth-year student pursuing Bachelor of Science in Nursing and Public Health at Kratna University. I'm here to give us an overview of what we're doing to combat tuberculosis, which in our opinion is a public health concern. So to my first slide of introduction, tuberculosis is a public health concern. In 2022, globally we had 10.6 million infections of tuberculosis. 2.5 million were Africans. 2.5 million were Africans. Out of the 2.5 million, 1.3 million were Kenyans, and we ended up losing 400,000. From 2022, the government has made strides to combat this disease. We know counties like Siaya County have tried to integrate AI in this diagnosis. As at February of this year, we have 350 new patients of tuberculosis. As at now, like as we speak, 350 of them. We end up losing 14 patients to TB every day, like on a daily basis. So assuming leo jioni, today evening when we go home, we are losing a whole matatu of people to one condition. The sad thing is 33% of these people are either misdiagnosed or they took much time in diagnosis. Either the strain wasn't identified or they were misdiagnosed to have pneumonia or something of the sort, or some other respiratory condition. And therefore, we thought to ourselves that with this freeze of United States where we don't have funding coming again on TB and HIV, how can we get our homegrown solutions? And ladies and gentlemen, we identified 3 problems: misdiagnosis, high cost of medication, and challenges in strain identification. In our presentation, we have categorized strain into 2. Susceptible to medications and resistant to medications. So what is our solution? Ladies and gentlemen, I propose to you an AI-powered diagnostic tool that will interpret chest X-rays for rapid TB detection and strain identification, as well as communicating the same information to our healthcare workers. So these happen in 3 key steps. On slide around 4. These happen in 3 key steps. How does this model work? So we have created the system, which I'll show you at the end. I'm having an active prototype. So the healthcare worker is going to sign up and log in. Then from there, you upload the chest X-ray, then you download the results. As simple as that. And with that, we can get the TB. We can get if you're having TB or not, and we can get the strain that you're having. So you don't have to go through the process of tuberculin test. Why do I propose this solution? What are the advantages? 1, it is faster, it is scalable, and it is cheap to diagnose TB. Today in the morning, we were talking about over-reliance on donor funding. So with this, if we get if we get the funding once, we are done and good to go. We have identified several revenue streams, around 6, that once we have injected money for like a seed investment, we have 6 revenue streams that are going to ensure that we don't come back to the donor for requests. And the 6, as I'm going to mention, include subscription, pay-per-use, data analytics, training and support, and licensing. So we're going to license our users, we're going to sell this to people, and we are going to be able to generate revenue. So we have identified a number of customers and partners. So of our partners, everyone who's here is able and open to partner with us. We're having Ministry of Health, NGOs, county government and national governments, and diagnostics hospitals, setups, I mean. So our targets, our customers are the hospitals, the NGOs. Those who are doing research on TB can also work with us. Why would you be prompted to work with us? We have a 3-layered pricing system, which is fluid and pocket friendly. So you can either do it in 3 stages. We have level 1, 2, and 3. So level 1, you are an unsubscriber to our product. So when you are a non-subscriber, you pay per your use. So if you're like a small facility, health center that don't need to be doing a number of chest X-rays, you just pay per use. So if you get like, let's say 3 per week, you don't have to subscribe. You just, for the 3, we invoice you. We have semi-annual subscribers and we have annual subscribers. So these values, the next slide, these values are negotiable. So we are estimating that for every use, you're going to pay between 100 and 200. For semi-annual, 50 to 60,000. and for the level 3, which is annual 90 to 100,000. So ladies and gentlemen, what is our aim? We aim to empower healthcare workers with advanced AI-powered diagnostics to detect TB and identify strain with unprecedented speed. Our solution, as I had mentioned, is scalable, it's affordable, and can be used pale mashinani. So we have a list of timelines. Please go to the second last slide, third last slide. We have a list of timelines. We started working on this project in November of last year. So we identified the problem, created the solution. So in December, nothing really happened. In January, we did the patenting. In February, we did the training of the model. We tried with a hospital back where we study. And school, of course, it was part of after they have done theirs. So we're just trying it. And now in February, we're looking forward at scalability. So I have a video that I had sent of how it works, if it can be played kindly, as I mentioned, what I mentioned. There's a video that I had sent. So what is my ask? We have sat down and analyzed this project, and it would cost roughly 18 million Kenyan shillings. Should I say $18? 18 million Kenyan shillings. So after we have invested these 18 million, we have now the revenue streams that are going to ensure that we remain sustainable and we won't be reliant on donor funding. So there is a video that shows how the project is working. There's 3 simple steps. You log in, upload the image, then it gets the result. There you go. So that is where you upload the image after you've taken the chest X-ray, then you wait for the analysis. So give it some time. It takes roughly 1 minute to analyze the solution, the chest X-ray. Yes, so that is the result. Overall result, TB detected. So when it does not give the strain, it means the TB, the bacteria is susceptible to the infection. Then it gives the reasons why down there, bar graph or features of likelihood. What we are doing, we have trained our model with a number of chest X-rays, so it looks for the similarities. Thank you so much. We are open to partnership and assistance. Asanteni sana. Have a good day.
Thank you. Very interesting, Luis. It's not in use yet?
We have patented. We're looking forward to scale.
Okay, but right now no one is using it yet.
No, but we are doing training. Yes, with health facilities. Yes.
Okay, thank you very much. I hope you find an investor in this room. Of course, trust the Gen Z to tell us about AI. I wonder how many of you in the room can use AI or use AI in your day-to-day life? Anyone? Oh, and you're a Gen Z, of course. It's only the Gen Zs who are raising their hands that they use AI. So I hope Lennox has challenged us to now think about how does AI provide solutions to the problems that we are facing in our day-to-day life, including healthcare and diagnosing illnesses that would otherwise take forever to diagnose. So next, we're going to hear about chronic disease management and how technology is helping to manage chronic diseases. And we'll hear from, I can see her coming up already, Dr. Samira Abdul Rashid, who's the medical officer in charge of telehealth at Maidawa. Karibu sana.
Thank you. Hi, everyone. Or should I say good afternoon? Okay. Thank you so much for being here till now in this heat. And I hope everyone has had their lunch. And does everyone else use AI as their therapist, like me? No? Yes, perfect. And we are not Gen Zs. Okay, so I'm Dr. Samira Abdul Rashid. I lead the medical team at Maidawa, and I'm honored to present to you some of the impacts we are making in the digital health space as Maidawa. Okay, so I'll give you a brief around My Dawa. I know a lot of us know the e-commerce platform that you go online, shop for your diapers and your skincare, but I promise you we are more than that now. We have an end-to-end digital health platform. Ever since 2017, the founder had a bold mission to make healthcare in Kenya more affordable, more accessible, and trusted by everyone. So we started operating in Kenya, and now we have our services in Uganda as well. And with our services, it's ranging from the e-commerce platform that we all know and love, hopefully, and also our telehealth platform where we offer virtual consultations. And we also have now the last mile delivery that has a medical professional at the last mile as well as your normal riders. We identified key problems in the market that we hope to solve. And some of those are things like high cost of medication, parallel imports, inadequate access to care, fragmented access to healthcare, especially for chronic patients who are requiring continuous healthcare support, patients requiring discrete services such as HIV services, prevention services. And what we did is we tried to disrupt the supply chain and source directly from pre-approved suppliers in Kenya to offer high quality medication but at a cheaper rate to our clients. And then we also deliver to all the 47 counties in Kenya. We also ensure that you get, what you get from My Dawa is 100% traceable and legitimate. And we didn't stop there. We've partnered with insurance partners to reduce the cost, and we are helping institutions and retail pharmacies across Kenya get access to high quality medication, like life-saving medication like insulin at 30% cheaper rate. And above all this, we are putting the woman, who we call a true chief health officer of the home, at the center of our innovation. Allow me to just figure this out. Okay, cool. So we are reimagining care at My Dawa, and what that entails is that we have this impact so far with our telehealth solution. And what that looks like is that our virtual services have managed to help over 200,000 Kenyans since its launch in 2022. And with over 3,000 of those being chronic disease management patients who are being taken care of on a month-to-month basis. Okay, and also for our innovative engine, we have come up with telehealth care pathways, which we'll look at in the next slide. So we have 3 innovative programs that we have launched and have successfully seen clients enjoy. We have used AI as well, for HIV self-testing, for validation for both the patient and the clinician. So what happens to the patient is you don't have to go to the nearest CCC to get your blood-based testing and face stigma and long queues and maybe avoid even the testing and just go on with your life. What you can do now is you can get a blood-based HIV self-test and have an AI component in the back that validates how you can take your photo, how you can interpret your results, and give you the confidence that you have a negative result or a positive, and what to do when you get a positive. And then the other innovative solution that we have come up with that I'll talk about briefly in the next slides is also Zima chronic care model. And then lastly, we have home care, which is innovating in the family planning space, where we are looking at how to empower our women out there to enhance their self-care access. So access to self-care in terms of DMPA, injectable family planning that you can inject yourselves, or have provider-initiated injectables, as well as short-acting reversible contraceptives and long-acting reversible contraceptives. So we'll look at that in the next few slides. So for our HIV prevention journey, we have been part of an innovative study where we have managed to prevent HIV infection in over 3,000 clients in Nairobi and Mombasa. And how we did that was by use of a blood-based HIV self-test, online counseling that replicates the standard of care on ground in our CCC centers, and as well as last-mile delivery of your HIV prevention medication, which is PEP and PrEP. And with that, we have served around 2,500 PEP clients, and the rest were PrEP clients. PrEP is normally the pre-exposure, and then PEP is post-exposure after an event has happened. And our next step in this study is we are hoping to inform policy. So currently it's not the standard of care in Kenya to go through a telemedicine visit and get your HIV prevention care. But we are hoping that once we inform policy, then other players in the market can also offer this life-saving medication. Then our next project is family planning. So we are looking at enhancing our care through the online journey. What makes that young girl go to an online pharmacy and buy a P2 every other month? What can we do in our counseling to ensure that this young girl buys a short-acting reversible contraceptive as opposed to that P2? That's what we are looking at. How do we enhance our counseling journey? How do we enhance our user journey? What do we do on our platform so that we can reduce the incidences of using P2 and eventually altering your hormones in your hormonal profile? And then part of that is expanding the method choice, methods that are available through the online model. Maybe you're not finding these methods that are working for you through the online platform. So once we expand these methods, are you able to go online and shop? And then once you have a guidance and counseling person who comes to your house and talks to you about this product and how to inject yourself and gives you the confidence that after every 3 months, actually you can get a contraceptive method, then will you use this as a method of choice is what we are also looking at. And then for our Mzima program, which is the last one, we are looking at chronic care. So we have fragmented care in the chronic journey. We all know this. We have clients who are seeing their specialist after every 6 months, but in between, there's no one to talk to them, guide them, empower them to be self-monitors, empower them to have self-monitoring devices in the house, or even if they have, they don't buy the extra strips or they don't buy the battery to recharge their BP machine. So what can we do in the journey to help them take care of their chronic health journey better is what we are doing for this program. So we are coming up with discounts, we are coming up with incentives, like coming up with focus groups where they feel comfortable to have a community where they can talk to each other as well as the doctor, and then set up an infrastructure where they still have their specialists, but they also have a clinical guidance where every month they don't have to remember to refill their drug. There's someone who calls them and refills their medication for them, reminds them about their nutrition care, their psychosocial support, and so on and so forth. And so far we have around 3,500 clients enrolled into the program, and we have around 3,500 clients enrolled into the program, and they are benefiting from this chronic care journey. And why do we do this? Yeah. So we said that healthcare should not depend on where you live or how much you can earn. So just because you're in a remote area doesn't mean that you can't get access to high quality medication. And that's what we are aiming to do this for this project. So last but not least, my Dawa story is a story of possibility, that technology, when grounded in empathy and purpose, can fundamentally shift how we deliver healthcare. And I know that we are not the only players that are doing this. And we want to invite all of you to work together so that we are not working in silos and we are working in collaboration with each other. So that patient's chronic care journey doesn't stop at the hospital, but also continues beyond the hospital. Thank you.
Thank you so much, Dr. Abdul Rashid. I'd now like to call Jotham Alumasa, who's the Chief Operating Officer at LCT Africa, and he will talk to us about biometric end-to-end technology.
Thank you. Good afternoon. As you've heard, my name is Jotham Alumasa. I'm the CEO at LCT Africa. And LCT Africa is a technology provider current in the market. We offer an end-to-end solution for administration of healthcare. So I've had the previous speakers focus mainly on clinical, but health financing and administration is also as important as clinical is. So for us, we provide a platform where we incorporated artificial intelligence, blockchain, and analytics to be able to reshape how we view healthcare as we know it now. So just move to the next slide. Okay, so we've identified some critical areas within healthcare administration that as LCT Africa, we are trying to ensure we solve for that. And one is the complexity of managing medical insurance schemes. We have all witnessed the complexities of managing SHA as a scheme and SHIF. We are also trying to resolve the inefficiencies that are there in the traditional processes, which are predominantly manual. There's also a very high cost in terms of administration of medical, which is driven by various factors. Some by the cost of equipment, cost of products, and also cost of personnel. So on our side, we're trying to partner with telemedicine providers, what Dr. Ari spoke about here, what Idawa is doing to be able to lower these costs. And at the end of the day, our aim is to ensure that our patients who are the members of these schemes improve in terms of their health outcomes. So our mission at LCT is to make quality care affordable. And we've done this through some of the features that we've built in the platform. So our platform is predominantly biometric. So biometrics is our primary mode of identification. We do have a failover mechanism to default to OTP and QR code, depending on the case that you're managing. We also provide a very seamless member and benefit management module. So this is the module that we use to, one, check on eligibility, and two, administration of benefits. So we have a real-time deduction of these benefits, and that generates a claim automatically. So our claims module is very robust. We've revamped it. We've included AI on 2 steps. One, in adjudicating pre-authorization. So once we get a pre-authorization sent through LCT platform, we are able to adjudicate both financial and clinical information in that pre-authorization, and we're able to give a response back to the provider, whether it's an approval, whether we need more information, or whether it's a decline. So this helps in terms of managing the wait times that our patients have been experiencing in hospitals. And I'm so sure most of you, if you have insurance, you've experienced that, you've experienced when the cashier tells you that you have to wait, your insurance has not approved the pre-authorization. So we are solving that through automated pre-authorization and incorporating AI into it. And of course, in the long run, we want to benefit from the data that you're collecting, and not only just store this data, but also use this data to make decisions. So we have very advanced analytics on the LCT platform, and the analytics, we're going to use it to ensure that the decisions that we make in future are actually data-driven as opposed to instinct as we've been doing it before. So just move to the next slide. So as I had mentioned earlier, claims adjudication. I know providers, and Gertrude's included, you've had challenges with insurance companies settling your claims between 60 to 90 days. So how can we make this process efficient? So we are adjudicating on these claims within 10 seconds of full documentation and receipt on LCT. So that will help us reduce the credit period, because currently we are in negotiations with other players in the market, predominantly banks and other credit providers. How can we be able to plug this gap and be able to settle this claim within 2 weeks to a month, so that we can be able to solve the cash flow issues that currently are being experienced by hospitals? in them claiming from insurance companies. I've already talked about the pre-authorization journey. So I'll just move to the impact of this. And these are some of the issues that we are trying to solve. The claim processing time between 90 days, 30 to 90 days, we reduce it to a few hours, make a decision on what is payable, and avail sources of finance to be able to pay this. Claim rejection rates, with the compression of AI, we aim to reduce this by 70% because currently there's a lot of information mismatch in terms of ICD-10 coding errors that we're getting while documenting these claims, and also eligibility mismatches. So AI will come in and support that. The other issue is fraud and abuse in claims. And you'll notice that if you're a medical service provider, the reason why we have very stringent processes currently is because of lack of trust. So that is something we're really investing hard in. We want to have trust in the entire chain so that when a member presents themselves to hospital, the insurance company does not have to take you through 5 levels, have to verify biometrically, have to sign a claim form, have to sign a pre-auth form just for you to get service. All that may be because of the fraud and abuse that has been there in the market. So we aim to significantly reduce this. Of course, not total elimination, but we'll be comfortable at the levels at which we'll reduce this too. The other thing is one of the cost drivers actually is administration cost. So when we price these medical insurance policies, one of the key components in part of the price is actually administration cost. We employ a lot of hands to be able to verify these claims, to be able to do this pre-authorization, to be able to do underwriting. How can we then make this process more efficient? So with AI incorporated in our streamlined workflows, we aim to reduce this administration cost, and that in itself will be able to reduce the cost of one, medical insurance and cost of healthcare. And that will speak to what the government is trying to do in terms of affordability of a medical scheme. We can be able then to have higher penetration levels, which are currently at 3%. So you can just move to the next slide. Yes, so for us as LCT, we want to request you as innovators in the industry, as GOK, as the medical practitioners, that you join us and be part of the change that is going to happen in this industry. We are moving from the traditional processes which are manual. So embrace technology. Let us not just use technology as an enabler in business, but we should allow technology actually to be part and parcel of how we run business in this space. So thank you very much for listening to me. Thank you.
Thank you very much, Jotham. Actually, in 2025, you can't afford not to have technology as part and parcel of your business, because utaachwa nyuma wakati dunia inaendelea mbele. And then you'll be, in 10 years, you'll be asking, in fact, even 2-3 years, you'll be asking, who moved my cheese? So technology in 2025, we don't have an option but to adopt. So to close this session, I'd like to call upon Nigel Thuku, who's a data scientist from the Aga Khan University, and he'll be talking about building the future of health research, one record at a time.
Right, thank you, Zainab. My name is Nigel Thuku. I'm from the Aga Khan University. Specifically, our department is the Data Innovations Office. And I mentioned that because today I will be presenting to you an innovation that we've developed at the university, and hopefully be able to show you how this innovation is contributing to our goals of universal health coverage. But first, reality check. So, we're losing about 530 mothers for every 100,000 live births in Kenya, way above our global average. For the deaths in Kenya, 4 out of every 10 of them are from preventable, non-communicable diseases. And all of this is being handled by one doctor serving over 5,000 Kenyans. This challenges not only underscore that there are resources issue, right? It's not just a resource issue because we're not expecting more in that regard. So we need to be smarter with the resources that we do have. To be smarter with the resources that we have, we need to have the right kind of information, high quality, reliable data. Right? And that's what we're working on. So with this kind of data, you can not only make informed decisions about policy, but you can also provide informed care for your community. And with this idea of providing quality care, informed care, is at the heart of universal health coverage. So I'll be presenting to you in the next few minutes one innovation from the Aga Khan University and how this innovation is aiming to provide this kind of quality care. All right. So over the last few years, we've been working really hard to develop a health data repository that is turning out to be among the largest to come from a low and middle income country. At the heart of this repository is our electronic health record system, EHR for short. This system not only enables us to manage the administrative workload of providing care, but also enables us to capture data throughout a patient's journey, and that is important. So for example, you'd capture data around when you first register at the hospital, when you present symptoms, the diagnosis you receive, treatments, outcomes, and so on. So a rich wealth of information that we can gather from that journey. So we've been collecting data from that repository, and our Chief Medical Information Officer is in the next panel, and he'll talk more about that system. And this is what we have so far. We've collected about 3.2 million unique patients spread across Kenya, right? And from these patients, we can get history from running back almost 15 years. So the data is not only robust in its size of the population, but also it's longitudinal. So you can trace not only an individual's journey in healthcare, but also the population's journey. And we use the coding system. So the system that we use to be able to write down or to note down what diagnosis you have is a standardized system. It's called the ICD-10 system. And this is important because this standardized system enables anyone with at least this kind of knowledge of this standardized system to be able to use this data. So lowering the barrier for the use of this repository. And then, it comes from an EHR system, which is a system designed for administrative work. So it's not optimized for analysis. So what we've done is to organize this data in a way that anyone, a researcher really, without any data engineering experience, can go into this system and use it. So it's well structured, high quality, and optimized for analysis. And we didn't stop there. After our first initial pull, we're continuing to update this data every 96 hours. So far we have a data repository that is rich, that is longitudinal. It has a lot of patients, a lot of attributes, and is continuing to be enriched as we go along. So this is a repository we've been building so far, and we're already starting to see value from this repository. I'll speak about a few projects. There are many, but I'll just highlight 3. So for example, research studies are already underway on gestational diabetes, on hypertension, and on sepsis. Why these 3 areas? Well, 2 key reasons. These areas present an opportunity in being able to develop solutions that are not only localized, so they're based on local evidence, but they're also preventative, right? And this is important because this kind of care would not only save lives, for sure, but it will also relieve our health system off of burdens of these diseases. And the second reason that we chose these diseases is because they also present an opportunity for us to show that we are able to develop innovative solutions off of our own data, and that is important. It will kickstart a process where we will continue to develop more innovative solutions towards the diseases that burden us, right? And second, and importantly, we're not just in the business of accumulating data. We want to get it into the hands of those who can use it the most. So one way I told you about is how we've organized it. It's a simple structure that anyone can understand. A second way and a cool way that we're experimenting with is large language models. So large language models are part of AI. So imagine if you have an interface, just like ChatGPT, and your doctor, clinician, data scientist can use this interface and type in a question in natural language. So for example, you could ask, how many patients in the last 5 or 10 years that are female over the age of 35 have been treated with hypertension? And the system, that interface, would be able to understand your question that is in natural language and convert it to a form or to a code that can be used to query against this database, so to retrieve information from this database and for you to assess. And that is what we mean by democratizing knowledge, lowering the barriers for the use of this data such that anyone who has the knowledge, the medical knowledge to use it, but not necessarily the hard coding skills, can also be able to use it. And we're seeing really promising results in this experiment. Now, Zainab, in conclusion, this is our contribution to universal health coverage. The idea that we are providing information that will fuel quality care that is locally informed and evidence-based. And we're doing this one record at a time. One record that brings us to better data, better insights, and better decisions. Now, if there's anything that I've talked to you about today that resonates with you, please feel free to write to our Chief Data Innovations Officer, and hopefully we can find a way to collaborate, find synergy, and move forward in our progress. Thank you, Zainab.
Thank you very much. That concludes our session of innovators. I hope you're listening keenly. I hope you see opportunities for partnership. And Louis was looking for an investor. I hope maybe somebody in this room would be able to point him in the right direction. So we're going to move on to the next panel. And this next panel, I'd like to invite my colleague, Bridget Singana. I think she stepped out of the room. Someone will find her. So Bridget Singana's panel is going to be talking about the role of digital health, putting into context the conversations you just had, putting into context the innovations that you just had from the innovators, which are some of the other innovations that other health players are putting into place to bring this conversation home, to address the challenges of UHC, to address the challenges of health. And this panel will focus on digital platforms, AI, telemedicine, electronic medical records, and blockchain in healthcare, all of which are things you've heard about from the innovators. So this panel will also tell us, put into context more. As I speak, I hope somebody can be putting the seats back up. We need 5. We have 5 panelists for this session. So this panel will also put into context the conversations we've just had and maybe elaborate further. So if you have any questions about what technology is being used where, how it works, please, like I said before, note it down, and then you'll be able to engage with my colleague Ngana once her session comes up. So try not to interrupt the session, but note down your questions. So in this panel, we'll have Esther Moloyos, who's Partnership and Liaison Senior ICT Officer, the State Department of ICT. And Esther will talk mostly about Kenya's digital health strategy. We have Professor Said Karar, who is a professor of internal medicine and also the acting chief medical information officer at the Aga Khan University Medical College. And he's going to talk about available research and data on AI in predictive healthcare. We'll also have Engineer Lenayara, who's the acting CEO, Digital Health Authority, Dr. David Kariuki from KMPDC, and Mary Musa, who is from Africa Health Business. So without further ado, I'd like to welcome Bridget Singana.
Thank you, Zina. Asante. Good afternoon, good people. Why do you look like you're not energetic? It's after lunch. Good afternoon. Thank you so much for being part of us. It's been a long day, a very packed day, but I am so happy and excited that what I'm talking about with my panel is about the future, and the future is here. So without much ado, I'd really like to welcome my panelists to the stage once we are done setting up. And I would like also to communicate the apologies of Engineer Lenayara Anthony, who's from the Digital Health Agency. I've just had a conversation with him on the sidelines. He is needed for an urgent meeting at the Ministry of Health headquarters, and so copious apologies on his behalf, and I hope also the other panelists will allow him to be absent, but you'll also feel some of his questions, so stray fire is coming your way. But thank you so much. I would like to start with ladies first. So, Madam Esther Molois, please welcome to the stage. Guys, this is going to be very interactive. I want energy to the max. So please clap for them as they come to the stage. Then we have Dr. Mary Musa from Africa Health Business. Welcome on stage. We have Professor Syed Karar from the Aga Khan University Hospital. Dr. David Kariuki from the Kenya Medical KMPDC, the CEO. Please welcome on stage. And finally, how many are we? We're supposed to be 6, minus 1, we are 5. So thank you so much. I believe we are, no, I think there's one person missing. Is it? Is it? Let not technology fail me, and I'm going to be talking about technology. Yeah, so welcome guys, you can test the mics. Let's find out if your mics are working. Let's check. I hope the sound team, we are good with the mics for the panelists. And thank you so much. I will take a seat and we will begin as soon as we can. Yeah, I think everyone has a mic. I can hear the noise. What could be the problem? So this year's Nation Media Group Health Summit is all about exploring the opportunities that the digital space has for us in the journey towards universal health coverage.